GI is more predictable than any other Step 1 subject, if you know what to look for, but most students don't. They memorize diseases instead of learning where pain localizes, what LFT patterns mean, and what actually triggers nausea. Today, I'm revealing exclusive footage from our paid course showing how to think through GI physiology. These 3 skills turn every abdominal vignette into a logic puzzle instead of a guessing game. Watch how thinking in physiology turns GI into free points. Hey, so before we move on to the next concept, if you want to go deeper on these and other high-yield topics, we have a free 14-day course that covers exactly what it is that we have found, helps students go from, in some cases, failing all the way to 260 plus. So be sure to click the link in the description to sign up. Today, we are going to transition to talking about GI stuff. And so I'm going to read this vignette slowly, as I would in the real world. And because again, slow is fast. And then we'll have you do the pathophysiologic chronology. So a 15-year-old boy comes to his physician for nausea and vomiting for the past 2 days after a school potluck. Several of his classmates and teachers reported similar symptoms. Temperature is 37. Blood pressure is 120/80, and pulse is 72. On exam, there is mild scleral icterus. Abdomen is soft, non-tender, and mildly distended. Labs are significant for T-bili 3.5, direct bili 0.3, alkaline phosphatase 40, AST 20, ALT 21. What is the pathophysiologic chronology? What is the significance of the total versus the direct bilirubin? Is the alkaline phosphatase normal? Why would that make sense? And what color would his urine be? So I'm going to put this in the Google Doc, and then I will have you guys do that. Physiologic chronology. So this is Gilbert. So in other words, if you said he was born healthy, that's not technically true. So he was born with the UDP glucuronidase activity down for whatever reason. And so he was asymptomatic until he had a GI illness. When that happened, he had a decrease in the conjugation of his bilirubin, which led to an isolated increase in his unconjugated bilirubin. So that was why his total bilirubin was high, but his direct, in other words, his conjugated was low. So if the idea of conjugated versus unconjugated or direct and indirect and all this stuff confuses you, this is the lesson for you. Also, if you're confused about AST and ALT and all that stuff, this is it. Whereas what we're going to talk about. So summary of key concepts. So as a reminder, bilirubin, right, is a breakdown product of heme, which is a porphyrin ring. Porphyrin rings are nonpolar. So again, I'll repeat all this stuff later, but this is just the overview. So when you break down heme, you get bilirubin, which is also nonpolar. Makes sense. Heme is nonpolar. When you break it down into bilirubin, bilirubin is also going to be nonpolar. Because it's nonpolar, if you want it to stay dissolved, or if you want it to not cross over and be absorbed by your GI tract, then you have to conjugate it. It happens to be conjugated with glucuronic acid by UDP glucuronidase, and that's what's deficient in porphyrin rings. Interestingly enough, so they are nonpolar, and they're nonpolar because they have a lot of conjugated double bonds. And so they absorb visible light, which means they are, for our purposes, they have color. So heme is red because it's a porphyrin ring, because it absorbs visible light because of all the conjugated double bonds. Or bilirubin is yellow because, again, it's also very nonpolar, has an alternating structure of double bonds with single bonds. Myeloperoxidase, so why pus is green, is because, again, neutrophils have myeloperoxidase, also based off of a porphyrin ring. Chlorophyll also is a porphyrin ring. That is why it's green, right? All of these things that have color in our world, many of these natural things are based on porphyrin rings. And because they have this conjugated double bond structure, right? Where you have double bond, single bond, double bond, single bond, double bond, single bond, double bond, single bond. That is why they have. That is why. It's cool. As we talked about, it's where you have decrease in UDP glucuronidase activity. It leads to an isolated, unconjugated, right? In other words, an indirect hyperbilirubinemia when you have periods of stress like this guy had. And then as a final reminder, we're going to talk about LFTs, but as a reminder that it's basically a misnomer. They are not actual tests of liver function, and we'll talk about why. All right. So we've got a lot of stuff. So let's start with Leah. So Leah, what is bilirubin? You just have to remember, you have to unmute yourself. There we go.
So bilirubin is a breakdown product of hemoglobin.
Actually, specifically, so what's the difference of heme? Yeah, what's the difference between heme and hemoglobin?
Heme, there are 4 heme molecules in a hemoglobin.
Good. Yeah, exactly. Hemoglobin is the protein, right, that contains the heme. Heme is the smaller molecule that actually binds to the oxygen. So Fong, what organ does most of the bilirubin in your blood come from? And why would that make sense?
You mean liver?
Actually not. No. The bilirubin goes to your liver, but what makes the bilirubin, so to speak?
So the spleen?
Yeah, very good. So why would that
Like
make sense?
breakdown.
Yeah.
Mhm.
Yeah, because that's where your blood cells are broken down. Great. So bilirubin is a breakdown product of heme, right? So the spleen is where you're breaking down all that heme. So it makes sense. And so Satya, is heme water soluble or not water soluble, and why?
Heme has protoporphyrin and iron. I would think it's water soluble.
Let's look at the structure. So I included it here. So is this very polar or nonpolar?
It looks non-polar.
Very nonpolar, extremely nonpolar. You are correct. Yeah. So if it's nonpolar, it's
So-
going to be water soluble or not, probably.
So it's not.
Yeah. It's very nonpolar, right? So you can just see, right? It's like, yeah, this is definitely not polar. Right. So in general, right? So they say likes dissolves likes. It's an easy way to remember it. So water is polar. Things that are not polar do not dissolve well in water. So porphyrin rings absorb visible light. Io, what color is heme when it's bound to oxygen, and why? It's just red. This is why your blood is red. Right?
Oh, gotcha.
It's hard to be put on the spot. This is good. It's good practice because oftentimes the questions are easier than you think. So yeah, so porphyrin rings absorb visible light. And so as do basically many things with conjugated double bonds. Fun fact, again, chlorophyll, which gives plants their green color, also is a porphyrin ring, which makes sense because porphyrin rings have a lot of conjugated double bonds. The conjugated double bond structure basically allows it to absorb light in the visible spectrum, oftentimes. So most things like dyes have a lot of conjugated double bonds, just in general, if you're interested. So Matan, what color is bilirubin and why?
Yellow color.
Yeah, it's like yellow. Yeah. Why is it colored and why is it not without color?
Well, it doesn't have oxygen bound to it, so that removes the darker reddish brown. I'm not sure exactly why it's yellow though.
Again, same thing. Sorry, I think I should rephrase these questions. Really, it's not why is it red or why is it yellow? It's why does it have color in the first place? It is color in the first place because again, bilirubin is the breakdown product of heme, right? Heme is colored, so it would make sense that if you break it down a little bit, that it would also still have color in it, right? Because again, both have many conjugated double bonds, and so they absorb light in the visible spectrum. You can see it. You can just see it here. You don't have to be a chemistry guru to see like double bond, single bond, double bond, single bond, double bond, single bond, double bond, right? Single bond, double bond. That is what a conjugated double bond is, right? We have an alternating structure, a double bond, single bond, double bond, single bond. So when you see that, you should think both A, nonpolar, and B, that it is going to absorb visible. Again, I'm trying to make this is like chemistry for MDs, right? This is very simple. So what color is poop, Moise? And why does it have color?
It's yellow or dark brown.
Yellow, brown. Yeah, brown. Yeah. Why does it have color?
I'm not sure.
Because again, so it's because it all comes from heme, right? So ultimately, it's all coming from heme. So
Right.
because you have bilirubin that's broken down into urobilinogen. The urobilinogen is broken down by so bacteria break bilirubin to urobilinogen, and from urobilinogen to stercobilin. So stercobilin is the brown thing. You can see it's very similar to bilirubin. It's extremely similar, and also has a lot of the conjugated double bonds, right? Double bond, single bond, double bond, single bond, double bond, single bond, double bond, right? Cool. Nita. So what color is P and why?
It's yellow because it's a breakdown product of bilirubin or heme.
Yeah, exactly. And so it has a lot of what?
Broken up heme.
Well, it's a lot of conjugated double bonds, right? So the urobilinogen, right? Just like for poop, just like making stercobilin. But so some of the urobilinogen is reabsorbed into the bloodstream. Some of that's filtered. And then in air, I think with oxygen, it oxidizes, presumably either from just the oxygen that's in the urine or in your blood. And so that becomes urobilin, and that is yellow. But again, you can see it's just the same thing. Like they all look very similar. So it would make sense that all of these things come from the same thing, right, heme, and that they would be colored. Cool. What important immune system enzyme uses a porphyrin ring, and what color is it? Myeloperoxidase. So in the respiratory burst, right, it actually contains heme, which is interesting, right? So it also contains a porphyrin ring. But pneumonia. What question can you ask to help you differentiate between bacterial and viral pneumonia, and why?
Maybe you could ask them the color of their sputum.
Yeah, you can. And that is actually what people do, what you're supposed to do. You say, do you cough? Is it productive? And then you ask, what color is it? So what color would make you concerned for bacterial pneumonia?
Green?
Yeah, green or yellow. What color would make you less concerned for bacterial pneumonia and think more viral pneumonia?
Maybe like clear, like normal color.
Clear. Yeah, exactly. Perfect. So you say, if there is sputum, what color is it? If it's green or yellow, that would indicate neutrophil presence. Since when the neutrophils break down, they're going to release their myeloperoxidase, which again contains heme. The heme, again, is a porphyrin ring, right? Blah, blah, blah. So it absorbs visible light, right? So if the heme breaks down a little bit, then you can actually basically get bilirubin. I'm pretty sure that's where the yellow comes from if you've got like yellow sputum. Cool? Yeah, all these things. Who knew? So Deb, so abuse, right? This is something that you guys should all, right, that are going to go into patient-facing specialties should be aware of. So if you suspect physical abuse, very few abusees will say, oh yeah, like I'm being abused. Oftentimes the way that medical providers will hear it is, oh yeah, I'm accident prone, or I fell down the stairs or whatever. What physical evidence can you look for that will help you confirm that it wasn't just they fell down the stairs one time, that it's actually like multiple episodes of abuse?
The location?
Yes, location is definitely one of them. So what about, this is not what I was looking for, but you're right. That is one thing. And that's something that shows up sometimes.
I'm sorry, what's your question?
So location is one of them, right? So you can get you have defensive injuries, right? So like usually it's their forearm. But what about the bruises themselves? How are they going to look?
Could it be because like frequent bruising and frequent?
Not just frequent bruising, but the age of the bruises. So remember, if a bruise is just bleeding into your skin. So when you bleed into your skin, the breakdown of that blood is going to follow a very stereotyped process, right? Meaning if I have 5 bruises all at the same time, they should all look the same as they progress. So if you just fell down the stairs one time and got a bunch of bruises, then all of your bruises would be the same color. They'd all be red. However, the thing that you should look for in physical abuse is look at the age of all of the bruises. In other words, older bruises are going to have more bilirubin in them because the heme has had more time to break down into bilirubin, right? Like, sad that we have to like think about this, but there is a scientific basis. Cool?
Very cool.
Yeah. So if the age of the bruises don't match, they couldn't have occurred during the same incident. So if some of them are red and some of them are reddish yellow because the heme is broken down into bilirubin, they couldn't have all happened at the same time. I remember once my grandmother-in-law, my wife's grandmother, there was like a problem in the hospital and she fell. And so you can do this also in radiology. So you can look at the age of, because you can see, because like fresh bleeding is going to be more dense on a CT. So it'll look more dense. You can actually look at the age of, you can estimate the age of like different lesions. Like if someone fell down once, or she fell, they were moving her and she fell from a very high height because she was getting like a scan or something. And so we were looking at the CT scan and you could tell that there had been like probably multiple falls because you could see that some of the bleeding was more dense, like some of the areas of blood were more dense than others.
Alec, I have a question.
Yeah.
On I'm doing Kaplan now. One of the questions was basically comparing an epidural hematoma and I think it was either subarachnoid or subdural. But the pictures in the description, one of them was a really bright white, which was the epidural hematoma, and the other one was a darker color. Does it make a difference where
that's actually exactly what I was just talking about. Yeah. So an epidural hematoma is going to present more quickly because it's an arterial bleed. So the blood is going to be more dense because it's going to be fresh blood, be more iron there. So remember, if you remember from the cardiology,
it should be venous blood.
Yeah. Whereas a subdural hematoma is typically like subacute. And so there is much more time for that blood to like the heme to break down and the iron to be resorbed. And so it will not look as dense.
Okay.
Cool? Yeah, same idea.
Right, I totally missed that.
That's a great question.
I wanted to know, it wouldn't matter the size of the bruise in terms of the color. If someone bruised themselves in different areas.
Yeah, if I had a gigantic
always...
bruise, the color should be the same. It's the age that will tell what the color should be.
Okay.
So we are on, I think, Suja. So Suja, is unconjugated bilirubin water soluble or not, and why?
It is not because it's nonpolar.
Yeah, it's super nonpolar, right? Yeah. So again, makes sense. Heme is nonpolar, bilirubin's nonpolar. So it makes sense that they would both be poorly water soluble. And so Feluke, so unconjugated bilirubin, will this be absorbed by the GI tract? Why or why not? You can, yeah. Because again, it's nonpolar. So generally nonpolar things cross pretty well. This is why like urobilinogen, which again is a breakdown product of bilirubin, can be absorbed by the GI tract and why it can end up in your bloodstream and ultimately your urine.
Thank you. I didn't know.
Yeah. So Feluke, what does conjugation of bilirubin do? Like, why would we do that? Why would we want to conjugate it?
It's to excrete it.
Yeah. So why? What about conjugation allows you to excrete it? You're right. Absolutely. But why?
Because we want to get rid of it.
Well, true. That's the teleologic thing. But like physically, what do you conjugate onto it? Ty, what do you think? Why does the conjugation of bilirubin allow you to excrete it?
Because it's water soluble, it's able to be filtered out by the nephron.
True, but unrelated. You are correct. But we do not conjugate it so that we can pee it out. We conjugate it so that we can poop it out.
Should I give it a try?
Please.
So if unconjugated bilirubin is absorbed easily, then is conjugated bilirubin not absorbed easily, and that's why it could be excreted easily?
Boom. Yeah, because you conjugate it with something that's polar, right? What's that? So glucuronic acid, right? The acid itself probably gives part of it away, but so it's pretty polar. So you conjugate it with something that's polar, so that way it doesn't get absorbed by your GI tract, and therefore can stay in your GI tract and you can poop it out. Good. All right, so let's talk about some of these labs. Let's try and dig into this. So Claudia, so what does it mean? What does direct bilirubin actually refer to? So you've got total bilirubin and direct bilirubin. So what does it mean to say direct bilirubin?
Is that conjugated bilirubin?
That is conjugated. It refers to the conjugated bilirubin. So technically, so if you're curious, just if you're curious. So the way that they measure it is they add what's called a diazo reagent, which basically goes, so if you have bilirubin, there's going to be the water soluble kind and the not water soluble. So it's going to split like oil and water. So the diazo reagent is going to go, it happens to be more hydrophilic. So it's going to go to the hydrophilic part, which is the direct bilirubin, right? Because the whole point of conjugating it is to make it water soluble. So it goes to the water portion of it. And so that's why, and it reacts with it and makes it colored. And so that's basically the reaction is what you're measuring. So it's called direct bilirubin because that's what you're actually measuring. That's the thing that you're actually measuring. They call it indirect bilirubin because it's the thing that you're only indirectly measuring. Kind of cool, yeah. So Saba, what does total bilirubin refer to?
Total bilirubin is both conjugated and unconjugated. So direct and indirect together.
Perfect. I meant to say Saba though, but that is correct. So Saba, what do you think? Indirect bilirubin. Use what it is to explain how you would calculate it.
I think you would do the total bilirubin minus the direct bilirubin to calculate the indirect one.
Perfect. Yeah, that's exactly right. So the indirect is the unconjugated, right? So it isn't directly measured, right? Hence the name indirect. So you can calculate it basically by saying it's the total minus the direct. That's it. So Saba, what is elevated? Is it the direct bilirubin or the indirect bilirubin that's more elevated here?
I think it's the indirect.
Yeah, definitely. Because 3.5 minus 0.3 means that your indirect, right, your unconjugated bilirubin would be 3.2. So almost all of this is indirect. All right. So Miriam, where does conjugation happen? In what organ?
In the liver.
Boom. And so the biliary system is split into two parts, the intrahepatic and the extrahepatic. So Miriam D, what would be considered part of the intrahepatic biliary system?
I know there's like the main vein and then there's like all these cells right
It's
beside
okay.
it.
I didn't know this. I had to look it up. It's the right and left hepatic ducts. So Rosa, so where's the extrahepatic biliary system?
It would be whatever is outside the liver.
Yeah, basically, everything that's not the right duct, the common bile duct. Great. So this is just something that's interesting, but do you happen to know, Shama, do you know what's the difference between PBC, primary biliary cholangitis, which used to be called primary biliary cirrhosis, but they changed it. So PBC, primary biliary cholangitis, versus primary sclerosing cholangitis. Do you happen to know what the
I
difference?
believe so. Primary biliary cholangitis is what used to be called like primary biliary cirrhosis, and it's autoimmune in middle-aged women, and it's intrahepatic like fibrosis, like duct fibrosis, compared to like primary sclerosing cholangitis would be extrahepatic like fibrosis.
Almost, very close. That was exactly
Okay.
right, except that PSC is actually both extra and intrahepatic. Cool. So PBC is intrahepatic only, and then PSC is basically both. But yeah, that was good. All right, Leah. So unconjugated bilirubin. So use whether it is water soluble or not to explain whether an unconjugated hyperbilirubinemia would lead to dark urine from so if you have unconjugated bilirubin in your blood.
Yes, it is because it's the unconjugated version is not water soluble, is what we talked about.
True, but why would it end up in your urine then? Because isn't your urine water?
So why would it go to your urine?
It doesn't actually. That's the punchline.
Okay.
It doesn't lead to dark urine. I love the thought process, but yeah. So it's poorly water soluble, and because of it, so I want you to tell me why it would not lead to dark urine, because your reasoning was correct. It was just the final step.
So we said it's not water soluble, so then it is not going to be excreted excreted in the urine, so it's going to stay in the blood.
Perfect. Yeah, because it stays bound to albumin. Most nonpolar things in your blood are bound to albumin, like just in general. Yeah, bilirubin being one of them. Or if you remember, like from biochemistry, right? Like free fatty acids basically bind to bilirubin. That's how they're transported in your blood. But yeah, so it doesn't. In other words, it doesn't end up in your urine. It stays bound to albumin. So how about Fong? So Fong, would a conjugated hyperbilirubinemia lead to dark urine or not? Why?
Yes,
It would. Good. Why?
because it's water soluble and it secretes from the liver cell and to the blood and get to the urine.
Yeah, exactly. So another way that you can differentiate between a direct and indirect hyperbilirubinemia on questions and in life is look at the color of the urine. Tea-colored urine or dark urine, it tells you that there's conjugated bilirubin, usually. Satya, so if you had a complete blockage of the common bile duct, what color would the stool be and why?
The stool would be pale because there's no bile coming in, and
Yeah, exactly. Specifically, there'd be no, bilirubin coming in. So if there's no bilirubin, there's no urobilinogen. There's no urobilinogen, there's no stercobilin.
Sterco.
And so there's nothing that's going to give the stool the brown color. So classically, they say like clay colored.
yes.
Yeah. Boom. Isn't that cool? I know what some of you guys were thinking at the beginning of this. You guys were like, oh my God, are we really going to be talking about porphyrin rings? Really? And he said that this was going to be step 2 related. So just by understanding that one principle, you can explain so much. The color of bruises, like how cholestatic, like how cholestasis is going to present, the color, like why you ask the color of sputum, why pus is green and yellow, right? All that stuff. So Io, if you had a complete blockage of the CBD, the common bile duct, what color would your urine be and why?
It would still be dark red in color, so it means that it's blocked. Is there a way it could find its way into the serum
It
and
does. It does. Yes, it does. Yep.
and the filter through the kidney? It would be dark red,
Dark. Not honestly red. Remember, because it's bilirubin, not heme.
dark yellow.
Yeah, just like dark yellow. Yeah. Just
Yeah.
like normal color, just really dark.
Amber.
Exactly. Because again, it's because think, and it's because you have conjugated bilirubin there. It's not the heme. So hemolysis can give you, right, like red blood or red. Myoglobinuria can give you red urine because the heme is still red. So the heme will make your urine turn red. And by the point that it's gotten to the common bile duct, you've got unconjugated bilirubin, goes to your liver, gets conjugated, then goes into your common bile duct. So if this is blocked, then all that conjugated bilirubin is going to back up into your liver and then enter your bloodstream. And so it's the bilirubin that's getting into your blood. And so that, because it's conjugated, as you pointed out, stays soluble in the serum. So that will be able to be filtered through the kidneys because it's not bound to albumin. And so that will enter your urine and it will just make the urine dark yellow. Cool?
Yes.
Yeah. Matan. So what enzyme performs conjugation of bilirubin?
It's that one with the long name.
It is.
UG. There's 2 of them. Oh, there is UDP. Am I right there?
So it's UDP, glucuronal transferase, right? So let's just break that down. So it uses UDP, right? So UDP is basically just the carrier molecule. So that's not really the important part for MD purposes. This is not the important part. The important part is the glucuronal part. So transferase just means it's transferring it. Glucuronal is the important part. So it's glucuronic acid. So I was just curious, so I looked up the structure. But yeah, so this is the glucuronic acid, this right here. And so what ends up happening is the bilirubin will bind to this right here, to this cover right here. So again, all you need to know with this is that this is pretty polar, right? This is a carboxylic acid. There's a bunch of hydroxyl groups here, but yeah, this is pretty polar, right? This looks pretty similar to a sugar, basically. This is a pretty similar structure to a sugar, right? So pretty polar. So this is it's the same thing, right? Just written differently. And so this is bilirubin, right? So bilirubin, which is very nonpolar, now has bound to this polar thing. And by binding to this polar thing, it is going to make it polar. All right. So great. So Gilbert, what effect does stress have on UDP glucuronal transferase activity? So Nita, what do you think?
I'm not sure. I guess it would decrease the activity of the enzyme.
Yeah,
Not sure.
good. That would make total sense, right? Why would it make, yeah. So I spent a long time looking. I was trying to find some really great principle that was like, oh, fasting or stress like always decreases liver enzyme activity, but it's not like that. It really is quite complicated. Yeah, this is just one of those facts you have to either accept or memorize. But yeah, so but again, remember, Gilbert always happens, like the classic one is like some poor medical student that's stressed and doesn't eat because they're cramming for a test or something, and then their eyes turn yellow because they've got an unconjugated hyperbilirubinemia because their UDP glucuronal transferase activity goes down. So, but yeah. So Gianna, So now use the genetic basis of Gilbert syndrome to explain what you would see on the liver function tests. What abnormalities would you see?
So I think as we discussed, the genetic basis was that it decreases the ability for bilirubin to become conjugated. So based on that, and we said that the liver is the organ that does the conjugation, right? Maybe you would have decreased liver function. But I
Okay,
feel
so sorry.
like
So we're going to talk about liver function tests next. But what if I should ask, what effects does this have on bilirubin? Total bilirubin, your direct and your indirect B.
so your direct would be lower because you can't conjugate it. Your indirect would probably be higher because it accumulates because it can't become direct. And then your total, would it be the same?
Usually higher, but I guess in theory, maybe it could be, yeah, depending on when you catch it. But if they're presenting, presumably it's higher. So in order to see jaundice, I think you have to have a bilirubin of at least 2.5. Yeah, it is. If they're coming in, it's because they're symptomatic. So yeah, it would be high.
Right.
Yeah, so good. So UDP glucuronoltransferase activity is low. When they're stressed, it gets even lower. And so they can't conjugate bilirubin well. And so they get an isolated unconjugated hyperbilirubinemia. Great. So let's go through some labs. So Deb, so in our Gilbert patient, can you explain the bilirubin labs? So again, T-bili was 3.5, D-bili, direct bili was 0.3.
So the lab finding is indirect hyperbilirubinemia is compatible with isolated unconjugated hyperbilirubinemia in
Yes, perfect. Yeah, so problem with bilirubin conjugation, more unconjugated, so T-bili is up. However, because of the poor conjugation, your direct bili is not elevated, as Jenna pointed out. So good. And as you also pointed out, it's an unconjugated hyperbilirubinemia. Great. So the last part of this discussion is going to be about liver enzymes, and I wanted to talk about this in our first lecture because it's in all of GI is talking about the liver enzymes. So we're just going to go through this and we're going to make sense of it. So Sujith, what does LFT stand for?
Liver function test.
Great. And I put this in quotes, right? Because do you happen to know, Fulugi, what's included in the LFTs? The standard LFTs? Like the normal, there's 4 things.
Alkaline phosphatase, SGPT.
So bilirubin's one. So T-bili and direct. So usually it's total and direct. Sometimes they'll give you indirect, but usually they'll just give you total and direct. AST, which stands for aspartate aminotransferase. ALT, which is alanine aminotransferase. And as you pointed out, alkaline phosphatase, ALP, or sometimes you'll see AP, which are my initials. So I always remember that one.
I have a question. What about GGTP?
Those are not part of the standard LFT panel, but you are correct. GGTP, gamma glutamyl transferase, is sometimes, right? But that's not part of the standard panel, usually. It's usually just these 4.
Thank you.
So TI, so AST, right? Aspartate aminotransferase and alanine aminotransferase. Are these normally found inside of cells or outside of cells? Like, in other words, are they normally found in your serum or are they normally found inside of some cells?
I think they're typically confined to the liver.
Yeah, they're a little bit more broad than that. I think it's like in muscle cells in general, and ALT is found in some other things. But yeah, but generally they are only inside of cells. They should only be inside of cells. So in other words, AST, ALT, these are supposed to be liver cells, right? So they are normally found only inside of cells, not in the bloodstream. They would only be found in the bloodstream in very small amounts. So TI, so when we measure these LFTs, what are we actually measuring? Like, where are we actually measuring it?
In the serum?
Yeah, we're actually measuring it from their blood. You do venipuncture, you draw some blood, and then you're looking at it in the blood. But again, these are only supposed to be found inside of cells. So Claudia, so AST and ALT. So if these are elevated on a serum test, what does this indicate?
Cellular damage.
Exactly. So this is one of the things that really confused me when I was a medical student. It was like, oh, we're measuring these enzymes. So I was like, so there's more enzyme activity in the blood? I don't understand. It's actually much more simple than that. And as Claudia very, very clearly pointed out, there's damage. If there's damage to these cells, then the enzymes, the AST, ALT that would normally be there, are now suddenly found inside of the blood. So if you have usually liver damage, right? So if I have liver damage, then the AST and the ALT from inside of the liver cells will now spill out because I've got cell necrosis or damage, and it'll be in the blood. And so when I measure it in the blood, it won't be elevated. This is basically the same idea behind measuring just about any enzymes that we measure in the blood, like troponin, CK, right? All that stuff. Same idea. LDH. So Paula, so alkaline phosphatase, right? What organs release the majority of it? Saba?
Is it the bone and gallbladder?
Oh, pretty much. Not necessarily gallbladder. It's actually liver, which I was actually surprised with. I actually didn't realize. I had to look this up. I was like, I wanted to make sure. But it's actually liver, which is interesting. I actually didn't know that. But bone, yeah. So bone and liver. So you can also, just for your knowledge, it's also released from the placenta. So sometimes on questions, you'll have some pregnant women in the first trimester, and she'll have high alkaline phosphatase. You should still probably check a GGTP just to check, but it's probably from the placenta often. So yeah. So what role is it thought to play, Jay? Do you happen to know what role it's thought to play in bone? I don't think I knew this at your stage.
I know it's released if there's bone breakdown.
Interestingly, it's actually released when there's bone buildup. It's actually thought to have a role in normal bone mineralization. So phosphatase will cleave pyrophosphate, which is a complex thing, but pyrophosphate generally will inhibit bone. So it destroys an inhibitor of bone formation. So it's a double negative, right? So it destroys an inhibitor. It inhibits the inhibitor, so it causes bone mineralization. Thought to be. The funny thing is that no one actually knows what alkaline phosphatase is used for. I spent a lot of time looking, but everywhere I looked, they said, we don't actually know what most of these alkaline phosphatases are doing. I was like, oh. So Miriam D. So use the proposed role in bone to explain what bone conditions it's elevated in.
Anytime you have bone turnover, so I would say osteoporosis, osteomalacia.
So close. You are correct about the osteomalacia. So vitamin D deficiency, right? So kids are osteomalacia, right? It's not, you don't really see an osteoporosis so much. But anytime that you are actively making bone or you are trying to make bone. So vitamin D deficiency, you're not sorry?
Like not in when you're losing bone density.
You would not see an increase in alkaline phosphatase if you're losing bone. But if your body's making bone or trying to make bone. So if you're making bone, like Paget's, you see an increase in bone. Vitamin D deficiency, you're not necessarily seeing an increase in bone formation, but it's like your body's trying to make more bone. That's why they say they have more osteoid, right? The osteoid is basically just like the collagen. So you are trying to lay down all that collagen and you're trying to mineralize it. You just don't have the calcium and phosphate to actually mineralize it. But you're trying to, right? Which is why your alkaline phosphatase is increased. Cool?
Yep.
Yeah. Again, interestingly, we don't really know what alkaline phosphatases are supposed to do in most cases. We've got an idea in bone, but that's about it. For the liver, I don't know. It's funny. We don't actually know what the kidneys are filtering out that's so bad. We know that it correlates with having high creatinine and urea, but it's not your creatinine and urea that are bad. So interesting how much and how little we know about medicine all at the same time. So Rosa, so alkaline phosphatase. So elevated levels indicate what in the liver? Why is this thought to occur?
In the liver, would it be production? No, hydrolipid.
Yeah. So, sorry, Saba asked the question. She said, would you also see elevated alkaline phosphatase in prostate cancer mets? I think so, yeah. Because prostate cancer, I believe, is osteoblastic. So if you're making more bone, then yes. But to return to Rosa's point, so elevated, yeah. So interestingly enough, so biliary obstruction, the thing that you must know, the thing that you have to understand is that biliary obstruction leads to an increase in alkaline phosphatase. So I thought for the longest time that this was because alkaline phosphatase spills into the blood, that you block the biliary tract. And so just like bilirubin, right, you conjugated bilirubin that basically spills into the bloodstream. I thought that the same thing was happening with alkaline phosphatase, that somehow there was alkaline phosphatase within the lumen of the biliary tract and that it would leak into the bloodstream. It turns out that's actually not true. That's actually not the reason. The reason is because you increase synthesis of it anytime you have biliary obstruction for reasons that are beyond me. I do not know why, but yeah, it's actually because of increase in synthesis. Because I think that's important. It's an important distinction to make because again, you would think if it was something that was, again, it's found in liver cells. So you would think that anytime that you had damage to liver, you would also see an increase in alkaline phosphatase, but that's not really true to the extent that you'd think, right? You would think that AST and ALT and alkaline phosphatase should all increase by the same degree if you had liver damage, like hepatitis. But that's not actually true. AST and ALT go up much more than alkaline phosphatase does.
Alec, one question. The normal levels for AST and ALT would indicate just the turnover of the hepatocytes, like the normal
damage to the cell membrane of hepatocytes, therefore allowing usually necrosis, right? But damage in general to hepatocytes. And so release of AST and ALT into the bloodstream.
If there is something that is causing major damage, then that's when we see the levels like substantially increase.
Yes, exactly. Yeah. So like usually it'd be like really bad hepatitis or shock liver where you get like ischemia to the liver for a long time, or acetaminophen toxicity, like really bad Tylenol toxicity to the liver. Yeah. Those are the classic ones. Yeah. Yeah, but it makes sense. Whereas alkaline phosphatase, again, sorry. I'm getting ahead of myself. So Shama, so if you see an elevation in alk phos, what test should you order next and why?
You would get a GGT to check if it is from the bone or just the biliary tract, the liver actually.
Yeah, exactly. And GTT. I don't know what's GTTP, transfer race. I don't know, because sometimes it's written as GTTP, but I don't know where the P comes from, in fairness. So it's more specifically, because so GTTP is found more in the biliary obstruction rather than elevation for other things. So yeah, so exactly. If you're trying to differentiate between bone or like placenta, so like in a pregnant woman, you're going to see an increase in alk phos. You should probably still check a GTTP just to see if they're having biliary obstruction or if it's just because of the placenta. Cool. All right, Leah, we are back to you. So in our Gilbert patient, explain the AST, ALT, and alk phos.
In alcoholics or patients that drink a lot, why is the GGT elevated?
I don't know. I looked for that. I don't know. It's a great question. It is true. GGTP is elevated in alcoholic patients, but I don't know why. If you find it though, I have faith, Matan, that you'll find it. If you find it, you tell me. All right, Leah. So in our Gilbert patient, explain the AST, the ALT, and the alk phos.
So the alk phos 40, I think, is within the normal range. And I think for the AST and ALT 20 and 21, those are both within the normal ranges as well. So the Gilbert patient he's born with the condition, and you're not having any sort of injury to the hepatocytes like we were talking about. So your AST and ALT wouldn't be expected to rise. And the alk phos also, the liver isn't, so when you're not having any bone issues and your liver's not being injured, I guess I would say. So same thing.
Again, this is why I know it sounds silly that like you should learn why alk phos is elevated, but remember, even though it's in hepatocytes, the reason why it's elevated is not because of liver damage. Usually when it's elevated a lot, like when it's disproportionately elevated, it's not because of liver damage. Why is it? Under what circumstances is alk phos disproportionately? Biliary obstruction. So you wouldn't expect, that's not a biliary obstruction problem, so your alk phos isn't elevated. So I loved your reasoning, right? You were like, it's a problem with conjugation. So you wouldn't expect the AST and the ALT to be elevated. That's great. But also remember that the alk phos wouldn't be elevated. You could use similar reasoning, but really the reasoning that I think would be more precise is to say you don't have biliary obstruction, therefore biliary obstruction or bone formation or a placenta. So you don't have alk phos elevated. That's good. Yeah.
I have a random question too, just about the alk phos. You said, I know the placenta thing, I've seen that before in questions, is if you have a teenager or something, I've never seen that in a question, but if they're like growing a lot, does that?
Oh, great question. Yeah, actually, in my reading of this, apparently children can have elevated alk phos. Yeah, like kids. I don't know about maybe. Oh, you mean someone going through a growth spurt? Presumably, yeah. I don't know.
I just hadn't seen that before, but
No, it's a great point. Yeah, it's funny because I was reading, I was like, yeah, if you Google it, you're like, oh, interesting. Like they'll list the populations in which you see it normally. But yeah, children are one of them. Matan?
Patients with fractures as well, right?
Yes, I think so. Yeah, because again, you're building bone. Yeah, it's pretty cool. I know. Yeah, it is valuable to learn why. I know that in medical school, they don't teach us this, but it is valuable because then you can basically predict, which is great, Leah. That was fantastic. It was such a good question, right? Because that's exactly the kind of reasoning that you want to have, both on tests, but also just in life and in your clinical practice, because it would make sense. It just makes total sense. All right, so Fong. So LFTs, use what is measured to explain why the LFT, the liver function test, is actually a misnomer. Miss is wrong, or I think bad. Nomer is namer, right? Nome is name. So why is it improper to call LFTs like liver function tests?
I don't know the answer. The liver function test is to test the liver function, yes, and the AST, ALT, and they are about to.
Is that testing your liver function though? AST and ALT. Like, what about your function is that testing?
The other liver function include like a synthesis and the.
Yeah, exactly. And so AST and ALT, does that give you a measure of their synthesis? Their synthetic? No. Alk phos, does that really give you a sense of their synthetic ability? No. Bilirubin, maybe. I guess I could be convinced of bilirubin because making direct bilirubin, sure, is the measure of their liver's function, but it doesn't really tell you, it's not really telling you about their liver function. So I'm not the first person to point this out, but calling them liver function is wrong, right? Because they're not really a measure of liver function. Certainly not of the liver function that we care about, which is that we follow most carefully, which is their synthetic function. So Satya, so what is measured instead? If we wanted to measure someone's synthetic liver function, how would we actually do it?
Synthetic liver function. That means not the excretion part.
Exactly. Synthetic meaning making stuff. So
Just
how would we
making
measure
stuff.
our proteins, our liver's ability
To make protein. For example, I don't know if ALT should count.
because again, it's elevated. So yeah, no, that would be not a great measure of liver function. Sure, you make it in the liver, but if it's in a hepatitis C patient who is like a failing liver, you couldn't really follow their ALT.
I was going to ask if PT or INR could be followed.
Yeah, perfect. That is one of them. PT and INR is one of them. Great. And then Rosa, what's the other one?
I said albumin.
Yep, you got it. Yes, exactly. So it's those two are the major ones. So albumin is one, and then PT is the other. And so let us go to IO. So albumin is made in the liver, right? And so most coagulation factors are also made in the liver. So again, if you have low synthetic function, you're going to have your coagulation factors are going to go down, and so your PT is going to be elevated. So if you actually want to look at, so these are the ones that we actually use. So if you want to test someone's synthetic function, the classic ones to measure are PT and serum albumin. And gosh, we run IO. In liver failure, what's affected first? The serum albumin levels or the PT?
I want to say the albumin.
Try again.
PT.
PT is affected first. Do you happen to know why?
Because if there's a decrease in the function, then there won't be production of the proteins, which is one of the proteins that it produces is the protein. So
True. Although, so the answer actually has to do with half-life. So what has a longer half-life, do you think? All of the coagulation factors or albumin?
albumin, I want to say albumin has a longer half-life, but yeah.
So if I were to stop making all proteins, what levels are going to decrease first? The
Coagulation factors will decrease first.
Exactly. Yeah. So PT is affected first. That is because factor 7 in particular has a very short half-life, somewhere in the order of 3 to 6 hours. So in other words, if I stopped making proteins, my factor 7 levels within 5 hours would be half. And then within 10 hours, 6 to 12 hours, they would be like a quarter. So that's very quick. So within a day, I would have basically very little factor 7. It takes about 5 half-lives to get to 5 half-lives to basically reach steady state or to have something clear from your body, be completely cleared.
Really quickly, is this why we would use PT instead of PTT?
Yeah. Yes, because PT is affected first. I presume your PTT would also be affected, but yeah, the reason why I use PT is because factor 7 has the shortest half-life of all of them, or at least my understanding. As opposed to albumin, as IO pointed out, albumin has a very long half-life. So again, 5 half-lives to go from 100% to 0, or to go from 0 to 100%. That's like semi-common pharm question for step 1. So it would only take about 15 hours to get to near 0 levels for factor 12, like less than a day. But for albumin, 5 half-lives is like 100 days. That's almost 3.5 months. So if the liver stopped making albumin, your levels wouldn't fall for a while. Cool? All right. So Matan, so acute versus chronic liver failure. So what lab values would you measure to differentiate between the two? And how would you use the results to differentiate between them?
So you do your AST and ALT. The ratio of the two helps you differentiate between acute and chronic, and specifically some of the causes of acute. I just can't remember the ratios offhand.
I think you're thinking like alcoholic versus viral hepatitis.
I am, and I know chronic fits in somewhere between the ratio 1 and 2.
So maybe I don't think I'm asking the question very well. If you were actually to differentiate between like synthetic failure, because again, remember liver failure and because the LFTs, although they are called liver function tests, aren't really telling you about the liver function. They're really just telling you about liver damage or bilirubin, right? / bilirubin production and conjugation. So like they're not really telling you about function. So liver failure isn't defined by a certain AST or ALT value. Liver failure is actually defined partially by synthetic function.
Yeah. So then I would use the clotting factors for PT, INR, and albumin levels.
Great. And so how would you differentiate? So what would if it was acute liver failure, what would be abnormal versus chronic? What would be abnormal?
Given the half-lives, you'd probably have a normal albumin level and an elevated PT, INR level.
In which?
And chronic would be deranged.
Perfect. Yeah. Exactly. And that's exactly what you're supposed to do. Yeah. So you'd measure the serum albumin in PT. In acute liver failure, your serum albumin would be normal because it's got a really long, like weeks. versus PT would be up. Because again, if your liver stopped making coagulation factors, right, your factor 7 levels would fall basically in a day, within like 12 hours. Versus chronic liver failure, that would be enough time. So if it was now weeks to months, your serum albumin would be much lower, as well as your PT would still be high. Your PT would be high in both cases, but your albumin would be normal in acute liver failure because it hasn't had time to fall, versus in chronic liver failure, it would be low. Cool. Perfect. These are the things that I wish that I had known. And again, they're not that hard. They're really they're really not that. So we are back at our vignette. So what I want you guys to do is, again, revise your pathophysiological chronology in the next couple minutes, and we will talk about it again and wrap up. Cool. So I want to do something a little different for this one. So instead of telling you my pathophysiological chronology, I'm basically going to read this question as if I was reading it for like real. So just to give you a sense of what the sentence by sentence analysis would look like for this question. So we've got a 15-year-old boy comes to his physician for nausea and vomiting for the past 2 days after school potluck. So we can assume that he probably got sick from the potluck, but that would be my guess. So pretty nonspecific. Probably several of his classmates and teachers reported similar symptoms. So definitely something. So definitely some sort of foodborne illness from the potluck. It's usually the potato salad, whatever has got like dairy. Temperature is normal. Blood pressure is normal and pulse is normal. So in other words, he's had nausea and vomiting, but it's not so bad that he's like, that his heart rate, because again, his heart rate would be high first. So the real big one is that his heart rate is normal. On exam, there's mild sclerolectrus. So now you're thinking like, so he's got nausea, vomiting. So you would be thinking, this is at the time, because up until this point, obviously you have no clue that this would be like Gilbert, but this would be the first clue. Sclerolectrus, so he's got jaundice. So you're thinking, honestly, you might be thinking hepatitis. So I probably would have been thinking hepatitis. It's like hepatitis, maybe. And so abdomen is soft, non-tender, and mildly distended. So pretty non-specific. Soft, non-tender tells you it's not. We weren't really thinking hid peritoneal signs, and mildly distended, probably just because of his nausea. I don't know. That's not specific. So the labs are really the key here. So in this case, he's got high bilirubin, but his direct is low, and his alk phos, his AST, and his ALT are all normal. So that tells you that this can't be hepatitis. So we'll learn about how to recognize the different patterns of basically bilirubin or LFT abnormalities in general, but this would be an isolated hyperbilirubinemia. So specifically an isolated unconjugated hyperbilirubinemia. So there's really not that many things like that. The big ones would be hemolysis, or would probably be the most common. So in this case, it would be Gilbert. And yeah, so I guess in fairness, I probably should have included his hemoglobin in this in retrospect, because in fairness, this could be hemolysis. And yeah, it'd be hard to tie that in with the potluck, but you couldn't eliminate hemolysis by these labs, because hemolysis would also look like this in terms of the labs. So cool. And so my pathophysiological chronology we already talked about. This is what it would be. And so any questions about that, about my analysis of that? Or you're like, nah, like that was not very good. This is how I would have analyzed it.
Dr. Palmerton, I'm a little confused about how several of his classmates and teachers reported similar symptoms.
Just same bad thing.
But then are we to assume that they all have Gilbert syndrome?
Oh, sorry. Oh, I see. Oh, great question. By similar symptoms, I meant that they all were nauseous and vomited, not that they all had jaundice. That is a fair question. The sequence, though, is, yeah, similar symptoms, because we didn't hear about the jaundice until the fourth sentence question.
Yeah, and what you said made sense, like syntactically.
But it's a very good question. Yeah, I should have made that more clear. Reported similar. Yeah, that's a good question. Yeah, this is why I like to do this, because yeah, I can see it. Oh yeah, probably would have added the hemoglobin. Probably should have added.
On that, I have a question. Like, what if you have some type of like DIC or some type of some bacteria creating exotoxin that would cause a type of intravascular hemolysis? Would this be?
But he'd be a lot sicker. DIC, to be that sick, you'd be a lot sicker. Like autoimmune hemolytic anemia would be the other one. It's a little bit less likely, but that would be the other one that I think would be possible. Would be autoimmune hemolytic. So in other words, to get that question correct, you would have had to have looked at the answer choices and determined hemolytic anemia. Doesn't make sense.
Why would he have been asymptomatic until the potluck?
Because he'd never had that kind of stressor before. Because there has to be some kind of stressor. So that's why it's like classically like a college student that's like pulling all-nighters, because you've never put that much stress on your body. Right?
Okay.
There's like
And
different
and so we assume that the liver experiences that stress, and then in response, it just really just stops. Like the UDP glucuronidase transferase just stopped.
Great question.
Thank you.
Other questions?
May I ask one question?
Of course.
How is this different from hemolytic uremic syndrome?
HUS? Oh,
Yes.
could this be HUS? Yeah, I guess. Because the problem is that nausea and vomiting are very nonspecific, right? So someone eats something, they get nausea and vomiting, and then yeah. So I guess in theory it could, but they'd be a lot more sick. HUS is they get like the whole point of these labs is that it's like his vitals are normal. He's only got very mild icterus. He's otherwise just pretty well. He's just got little yellow eyes. That's classically how Gilbert is going to present. They shouldn't have really many other symptoms. But yeah, like HUS, you'd be a lot more sick. And yeah, because again, like HUS, classically, you'll get like neurologic problems and you get kidney problems and you'll get hemolytic anemia and thrombocytopenia and a number of things. That's the classic pentat. Oh, this is fun. Oh, I like this. I don't know how you guys felt. I've been thinking about doing this of just instead of just rereading the question, just read it as if I was like taking the test. But this is, I think, could be.
Yeah, that was really helpful to hear your thoughts as you were reading each, I guess, symptom.
Cool. Yeah, I think I'll do that because it doesn't take that much more time. So Bruce says yes, very useful, as does Sujith. Great, awesome. We are back to our summary of key concepts. Again, I won't reread it, but it's fun, right? It's fun to think that something so simple like a porphyrin ring in heme can be tied to jaundice and bilirubin, right? There can be tied to the color of your urine if you have cholestasis, if you have biliary bile stuff. Right. It can be tied to the color of urine just period because it's a urobilin. It can be tied to the color of your poop being brown or the color of your poop being clay colored if you have no bilirubin getting into your stool. You can tie it to the color of your sputum. Your sputum, if you've got bacterial pneumonia versus if it's clear, if you've got viral pneumonia or just pus in general, right? The green color of all the wonderful green things in spring and summer. It's pretty cool. It's all very similar. Gilbert we talked about basically is a way of talking about all these things. And then we talked a lot about LFTs, right? Alk Phos, and how you can use the fact that it's increased in bone production to explain varied things like why would you see it in like children that are undergoing a lot of bone growth or in fractures or in biliary obstruction or all of these things. You can explain it. Why is AST and ALT higher in really bad liver damage? All these things. It all has a logical basis. So thank you so much for this. And yeah, I'm looking forward to next time. We're going to talk next time. About more about this. And yeah, we'll talk about, it's actually about Coombs. So
Alec, before you go,
yeah, please.
There's another disease. I think it's Crigler-Najjar or one of those.
Yeah, so Crigler, I don't know how to pronounce it. So Crigler-Najjar is where it's basically a really extreme form of where you basically have no or extremely low UDP glucuronol transferase function. So they present basically at birth, and it may not even be compatible with life depending on how severe it is.
Cool.
Yeah. Satya asks, can we do more PCs? That's super helpful. What do you mean by PCs?
The pathophysiological chronology. It's just helpful to think how you're thinking.
Oh, yeah. Oh, every
Yeah.
single time we do, this is what we end with, is the pathophysiological chronology. So
Cool. Thank you.
glad. Yeah, absolutely. All right, guys. Any other questions, thoughts, concerns?
I have one more question. How do we get from, I guess, the GI bug, the gastric stress, to the low activity of UDP? We already know he has low activity of the UDP gluconol transferase. Is it an elevation in bilirubin that causes that decreased conjugation to be a problem? What is in between gastric stress?
No,
and
it's
low
actually the stress itself causes the UDP glucuronol transferase activity to go down.
So your baseline bilirubin is
So
but you're-
normally like you have enough. So in other words, you have enough UDP glucuronol transferase activity without stress that you can conjugate all the bilirubin that you produce or a normal amount of bilirubin. It's
Okay.
just that in Gilbert, because I think under normal circumstances, UDP glucuronol transferase activity decreases. And so Gilbert, they have like slightly decreased levels. You can think of it as they have slightly decreased levels at birth. So normally that doesn't cause a problem. However, when you get stressed and your UDP glucuronol transferase activity decreases even more, now it suddenly becomes a problem. Now you do not have enough activity.
How does that explain the total increase in bilirubin?
Because you can't conjugate it. So because you can't conjugate it, you can't eliminate it.
Sorry, yeah, that makes sense.
Cool?
Got it.
Oh,
Yeah.
great question. Fantastic question. Yeah. I don't think I did not make that clear. So yeah, Cool.
I have a question to follow just that up. You said you can excrete the bin that's just formed. Wouldn't that go as bilirubin and just be out? Because I would think either it's conjugated or it's unconjugated. So if I'm not able to conjugate it, then the unconjugated bilirubin should just be absorbed through my intestine.
Yeah, exactly.
So then I will.
Your bloodstream. Or it
go-
wouldn't even
oh.
make it into your GI tract in the first place, presumably.
Oh,
Right.
yes.
If it's not conjugated, remember, like in general,
Yeah.
things that are non-polar are absorbed pretty well. Things that are not, the things that are polar are not. So morphine is very polar. It's like you have to take many times the amount of morphine orally as you would get, because oral morphine is not absorbed well because it's very polar. Fentanyl
Right.
is very non-polar. Fentanyl, IV and oral are like very similar in terms of their overall effect. That's why they make like fentanyl patches. That's why they make fentanyl lollipops, because you can absorb it really well. Non-polar. All right, guys. Well, thank you very much. Take care. So what we're going to do is I'm actually going to give you a summary before the lecture, before the actual like vignette that I'm going to present in a sec. I'm actually going to go through the LFTs again, which is what we covered at the end of the last lecture. And so this is because if you didn't see that lecture, if you weren't here, this will be important for you to understand what we're going to talk about in this lecture. In addition, it's also just a really important concept for GI generally. And so repetition is one of the keys to mastery. So a summary of LFTs. So LFTs stand for liver function tests. These are not, however, really tests of liver synthetic function. So they're pretty much a misnomer, right? Most people would agree that these they're not actually tests of liver function. And so they're also not really liver specific. So they're very much a misnomer. So bilirubin, right? So the components of most LFTs are traditionally thought to be bilirubin, AST, ALT, and alk-phos. So for bilirubin, bilirubin is a breakdown product of heme. So if you recall, direct bilirubin is conjugated, right? And it's conjugated with something that's water soluble so that it can be excreted. The breakdown of bilirubin ends up coloring both your poop and your pee, right? So the stercobilin makes your poop brown and the urobilin makes your urine yellow. Bilirubin is elevated in hemolysis, right? So in hemolysis, your indirect bilirubin would be really high because you are producing a lot of bilirubin and haven't had a lot of time to conjugate it yet. So the indirect or unconjugated bilirubin would be very high. It's also elevated somewhat in hepatocyte damage, where it's both direct and indirect, and in cholestasis, where it's mainly direct. So AST and ALT are enzymes that are found within hepatocytes. And so if they're elevated, it indicates that the hepatocytes that contained the AST and ALT were damaged. So normally you shouldn't see very much in your serum. If the hepatocyte bubble or balloon is popped, in this case, AST and ALT. Alkaline phosphatase is an enzyme that's found, then the contents of that balloon are going to spill into the serum, among other places in the bile duct facing hepatocytes and the biliary canaliculi facing hepatocytes. So it's in the hepatocytes. What's interesting is that it's elevated in biliary stasis, and it's thought to be from the synthesis. They've actually shown that it's from synthesis and not from hepatocyte damage. That's important because you would think that if it was just from damage, if it was just a mechanism that was not from synthesis, right, the AST and ALT, that it would rise in proportion to the AST and ALT. But that's not what so in biliary stasis, you increase the synthesis, and so the alk-phos increases a lot. It's also important to remember that it's found in bone, where its function is best understood. It's thought to increase bone mineralization. It's also found in liver, where the function isn't really known, and in the placenta, where again, the function isn't really known, among other places. So these are probably the ones that are most common. We talked last time about how in any time that you're making bone, your alk-phos will be up, right? So Paget's disease, young children who are going through growth spurts, bone fractures, things like that, your alk-phos will be elevated, which makes sense because it's involved in bone mineralization. So in acute liver failure, again, so LFTs are not actual tests of liver synthetic function. So the tests of liver synthetic function are PTT and albumin. So PTT is going to be elevated in acute liver failure, because if I can't make any coagulation factors, the ones that have the shortest half-life, in this case factor 7, which is a half-life of 3 to 6 hours, will fall very quickly. So within a day, you're going to have, if you just took out your liver, you would have basically no factor 7 within about a day, right? 5 half-lives. However, your albumin, which has a half-life of about 18 to 20 days, would be normal, because it has a much longer half-life. So acute liver failure, PTT is up, albumin's normal. In chronic liver failure, your PTT is up, but your albumin would be low, because again, now you've had enough time that has passed that your albumin has now decreased. Cool. So I just wanted to do this summary of the previous lecture because it is very relevant to all of GI, but especially what we're going to talk about today.
Hey, Alec, quick question. Last week we talked about it being the PT, not the PTT.
Oh,
Is it the PT? Factor 7 for the PT?
Yeah, good call. Thank you. Sorry. Yes, I did this late at night. So yes, thank you. Other questions? So we are going to go to the vignette. So I'm going to read this slowly. So a 28-year-old woman comes to the physician with 4 weeks of worsening fatigue and dyspnea. She is otherwise healthy. Her temperature is 37 Celsius, pulse is 98, blood pressure is 115/75, and respirations are 18. On exam, she has pallor, mild jaundice, and splenomegaly. Significant labs are shown. Total bilirubin, 6, direct bilirubin, 1, leukocyte count, 8,000, hemoglobin, 6.5, platelets, 210,000, and direct Coombs test is positive. What is the pathophysiologic chronology? Specifically explain the proportion of bilirubin that is direct versus indirect, her hemoglobin and splenomegaly, her pulse and her symptoms, and the significance of her direct Coombs being positive. So I'm going to copy and paste this into the Google Doc, and I'll have you write your pathophysiologic chronologies. So I'm going to go through my pathophysiologic chronology. So the summary would basically just be she has autoimmune hemolytic anemia. So she develops anemia, and that's why her direct Coombs is positive. And so because her blood is carrying less oxygen, because she's anemic, she has to now increase her cardiac output to compensate for the lower oxygen content of the blood. So you can see the detailed pathophysiologic chronology, which actually I'll put these into the Google Doc so you can see them. But this is, you can see the more detailed one. So the detailed one is that born healthy, there's not really clear why it happens, but she develops antibodies against some sort of protein antigen on her own red blood cells. This leads to T cell dependent B cell activation. So again, protein antigen. So protein is presented to T cells. That leads to maturity, affinity maturation, and isotype switching, which is why she develops IgG, so the warm agglutinins. So this is known as autoimmune hemolytic anemia. And so immunoglobulin coated red blood cells are eventually cleared by the spleen, which is why she has splenomegaly. And so because the anemia, as we talked about, right, her oxygen carrying capacity is lower. So now she's going to have to increase her heart rate and to increase her cardiac output, and therefore increase the oxygen delivery to the tissues. Her red blood cells are already coated by, I should say, antibodies. And so that is why she's direct Coombs positive. So we'll talk about all of these things, but that is what we are going to discuss. So the summary of key concepts is, so the first thing we're going to talk about is T cell dependent B cell activation. So this requires a protein antigen. So you'll recall that MHC, which is what activates T cells, only presents protein antigens. Doesn't present carbohydrates, doesn't present fat, usually. So this leads to, when you have T cell dependent B cell activation, this leads to isotype switching, right, which is what allows you to switch from IgM to the different isotypes. It also allows for affinity maturation, right, so making higher affinity antibodies, and memory B cells. So B cells that persist in the circulation that can be activated against that antigen later. We'll talk about autoimmune hemolytic anemia, which again is usually IgG, so the warm agglutinins. And so the general thing that you want to remember is that all antibodies bind better in the cold. Almost everything binds better in the cold, right? The reason why we call them warm agglutinins isn't because they bind better at warm temperatures. It's just that they are such high affinity antibodies that they can still bind at higher temperatures. So they would bind better in the cold temperatures, but because they bind so well, because again, they've undergone T cell dependent B cell activation, so you have the affinity maturation to make higher affinity antibodies, they can still bind at higher temperatures. We'll also talk about the Coombs test. So you have direct Coombs, which is where you take the patient's red blood cells and you look to see at whether they've already been coated with antibodies. So examples of this would be in a hemolytic transfusion reaction like this, right? The direct Coombs would be positive. Technically, this isn't a hemolytic transfusion reaction, but this would be similar, right? So in a hemolytic transfusion reaction, you give someone red blood cells and then they have some sort of reaction against those red blood cells, right? So that would be an HTR, hemolytic transfusion reaction. So the direct Coombs would be positive because the RBCs would be coated with antibodies that you would take out of the patient. An indirect Coombs takes the patient's antibodies so it takes their serum to see whether the patient is producing antibodies against known antigens. So like Kidd, Keller, Duffy. So examples of this would be before receiving a blood transfusion, patients receive what's called a type-in screen. So the screen is basically an indirect Coombs test to see whether the patient has antibodies against minor antigens that you have to look out for. So all of these things will make more sense, but this is the summary of key concepts that you can come back to because this is the roadmap. So let's start with Gianna. So Gianna, what is the B cell receptor and how does it affect the function of a B cell? What does it become later in the B cell once it's activated?
So it's an immunoglobulin, also known as an antibody. And so it becomes, in a mature B cell, it will become like an antibody because it will be released from the B cell and participate in, what's it called? Like the type of immunity, adaptive immunity, sorry.
Yeah, exactly. So basically the B cell receptor is what will become the antibody later. Exactly. Yeah. Perfect. So Joni, is it Joni or?
Yeah.
Perfect. So Joni. So as a bit of background, right? So you can activate B cells either with the help of T cells. So we call that T cell dependent B cell activation, or without them, which we call T cell independent B cell activation. So T cell dependent versus T cell independent B cell activation. So what are the advantages of using T cells? Most people don't know this. So there's 3 advantages. It allows for affinity maturation, which is sometimes called somatic hypermutation, isotype switching, which is switching from IgM to IgG or IgA or other isotypes, and then memory B cell formation. So Joni, do you happen to remember what MHC stands for?
Yeah, major histocompatibility complex.
Perfect. Great. And so Satya, so what's the purpose of MHC?
MHC is part of the HLA and is a marker for cells in the body specific to individuals.
True, that's how we use it, but how does the body use it?
Oh, MHC typically presents antigen that is within, a component of the antigen that is within a phagocyte, and just displays it out to the T cell.
Yeah, exactly. So MHC2 would be something that a phagocyte takes up. MHC1 would just be whatever protein is in the cell that samples it.
Yes.
But yeah, perfect, great. You can tell that you're interested in heme, or did at least heme work. Yeah, that's how they use them. Yeah. But the basic idea is that MHCs are there to present antigens to T cells. That's essentially right. That's like the USMLE view, right? So MHC1 presents it to CD8 cells, and MHC2 presents it to CD4 positive T cells. So Paula, what kind of antigens, like what molecule type does MHC present?
Cytotoxic T cell and helper T cell.
So is it carbohydrate, is it protein, or is it fat, or some combination?
Protein.
Perfect. Yeah, it's a protein antigen. Good. Exactly. Perfect. But Mary, what kind of molecules, so protein, carbohydrates, or fat, can activate B cells? Right, so T cells are activated by protein, but what kind of molecules can activate B cells? All right, we'll go to Sue. Sue, what do you think?
So cells can be activated by all 3.
Exactly. So they can recognize proteins, carbohydrates, and fat. And so let's think about, so Deb, so what kind of molecules, so protein, carbohydrates, or fat, can activate T cells, and why would this make sense?
Protein can activate T cells.
Yeah, and why?
Is it to do with the memory B cell activation?
So MHC, right, activates T cells. So what kind of molecule can MHC present? Protein, carbohydrates, or fat?
Protein.
Protein. So if MHC can only present protein, and MHC is what you need to activate T cells, then it would make sense that protein is really what you need to activate T cells. This is an important takeaway, right? Protein is the major molecule that will activate T cells. That is something you need to understand. So what are bacterial capsules made out of?
They are made out of polysaccharides.
Perfect. Yeah. Almost all of them. The exception is Bacillus anthracis. So anthrax has a capsule made out of protein, basically, right? Glutamate, the amino acid. But yeah, basically everything is carbohydrate, right? So strep pneumo, the capsule is made out of sugar, right? Haemophilus influenza type B, all the typable influenzas, they're typable based on their capsule. So they're all also made out of carbohydrates. Great. So Vi, so if I wanted a vaccine to promote IgG antibodies against a carbohydrate antigen, could I use only the carbohydrate antigen itself in the vaccine? Why or why not?
Hey, if I remember correctly, I think this has to do with the spleen. If the spleen is working, and one kind you have to have a protein conjugated to your polysaccharide, and I think that was in pigs. Here, and if their immune system is mature, then I think the polysaccharide alone is enough.
Close. So that's actually, so good points. Those are true. Those are true. So the short answer is no. And so the reason is because unlike B cells, T cells cannot be activated against a carbohydrate antigen, right? So if I wanted to make a vaccine against, say, so there's an unconjugated and a conjugated version of the strep pneumo vaccine. If I did the unconjugated version, and then in other words, it was carbohydrate only, I couldn't activate T cells. And again, remember, what are the things that what does T cell dependent B cell activation lead to? What are the 3 things that it leads to?
Yeah, the isotype switching, the affinity maturation, memory.
So in other words, if I don't activate T cells, I can't do affinity maturation. But in this case, the most important thing is I can't do isotype switching. So if I can't do isotype switching without T cells, then can I make IgG antibodies? So this is a sneaky way of trying to combine different concepts in a situation that's highly clinically relevant. Cool? So the vaccine, right? Many of the vaccines that are against the coronavirus, they're basically targeting the spike protein, right? thing that, it's called coronavirus because it looks like a crown because of all the spikes. So that's the thing that they've chosen. Many of the vaccines have chosen as their target. So it's a protein. So do you think you could develop IgG antibodies against it? Yes or no?
Yes, T cell dependent B cell activation because T cells can respond to protein.
Boom. Exactly. Yeah. Perfect. Yeah. So that'd be my guess. I don't know the answer to that question, but that would be my guess, actually. So this is, again, vaccines are obviously a lot in the news right now, but very important to understand. So conjugate vaccine. So Grace, what is the conjugated vaccine? And what's the purpose? Why would you do this in the first place?
Is it to keep it stable? Is that why
Maybe.
you would conjugate the vaccine?
It's a good med student answer. It's like vague enough that it's probably right at least some of the time, but that's not usually the reason why they do it. So it's a protein, right? So we are circling around this idea that proteins activate T cells, and T cells, if they activate B cells, give you a lot of advantages, specifically isotype switching, memory B cells, and affinity maturation. So let's say that I have a carbohydrate antigen, and now I conjugate a protein. So it's a sugar plus a protein instead of it being just a sugar. Why would I do that?
I guess to activate the immune system, is that?
Yeah, perfect. What part of the immune system specifically? T cells or B cells are you trying to activate with the protein antigen?
Are we trying to activate T cells?
Yes, exactly. So with the protein antigen, now I can present it on MHC, like Vi said, right? She presents protein. So if I conjugate a protein onto the sugar, I can now present that protein on the MHC, which again, only presents proteins. So if I present it on an MHC, what can I now activate? T cells or B cells?
MHC. So now we can activate
You can activate T cells.
T cells to then activate B cells.
And if I use T cells, now if I have T cell dependent B cell activation. So if I use T cells to activate B cells, what's the advantage of that?
No T cell dependent B cell activation.
So now you have T cell dependent B cell activation, right? If I have T cell dependent B cell activation, what do I have? What advantages does that confer?
Isotype switching.
Isotype switching, memory B cells, and affinity maturation. Vaccine, yeah. So the general idea is that you add the protein on in order to be able to activate T cells. I know this is hard. It's probably been like years since you've thought about this. I know you're studying precisely. This is more a test of myself to see if I can explain it. So hopefully I can do a better job moving forward. But the general idea is that you conjugate on protein. The protein activates T cells. If I can use T cells to activate B cells, then I have the advantages of these three things: isotype switching, memory B cells, and affinity maturation. I apologize. I don't think I did a very good job of explaining it. What questions do you have?
Oh no, you're good. It's just been a while since I've gone over NH1, 2, and T cells, B cell activation.
Yeah, it's the blindsiding setting, I think, a lot of you guys. So yeah. So know that this is a very common strategy for making vaccines against non-protein antigens. So like Hib, right? The Haemophilus type B vaccine is a conjugate vaccine. The pneumococcal PCV13, that's the conjugate one. There is an unconjugated version, right? There is of the pneumococcal vaccine, but the PCV13 is. And then the Neisseria meningitidis vaccine also is conjugated. But again, it's all to do this. It's to make better antibodies, to make IgG antibodies. So let's go to Leah next. So Leah, conjugate versus unconjugated polysaccharide vaccine. So what isotype would you expect in a conjugate versus one that's not a conjugate polysaccharide vaccine, and why?
So if you are conjugating it, like you were just saying, and we have the protein there, so you can make the IgG. If you're not conjugated, if it's polysaccharide, then you would only create the IgM because that's using the B cells for that. So you don't get the isotype switching.
Perfect. Yeah, exactly. So conjugate can make any isotypes. So usually it's IgG in this case, because you're injecting it into what eventually goes into their serum. And so an unconjugated polysaccharide vaccine, you can only produce IgM, and that's because you don't have the protein conjugate, so you can't activate T cells. If you can't activate T cells, you have no isotype switching, and you'll only make IgM. So Vi is asking, will we go over isotype switching the order it happens? Not particularly, other than to say the first one that you make is IgM. And then if you do isotype switching, it depends on the cytokine sort of environment, but you can make any of the others. I don't think that you have to go through a particular order. Like I don't think it goes from like IgM to IgG to IgA. I think you just go straight from IgM to IgA. Does that answer your question, Vi?
Yeah.
Yeah. So you always start with IgM, right? Which is why that's the one that tells you if it's an acute infection or not. And then after that, it can become. So we just talked about isotype switching, which depends on T cells. And so So again, isotype switching is where you have a protein antigen that's presented in MHC. That protein MHC complex can activate T cells, and with the T cells, you can activate B cells. And if you have T cell dependent B cell activation, you can have things like isotype switching, where you go from IgM to other types of antibodies. And you can also have what's called affinity maturation. So let's go to, I think we're on Zach now. So Zach, so what does the B cell receptor eventually turn into? We talked about this.
Eventually turns into an antibody.
Yeah, so eventually it's the FAB portion of the B cell.
Oh, okay, yeah.
Right? But yeah, it's the antibody, right? So Zach, when a B cell first makes an antibody, what is the relative affinity of the antibody for its target? And what's the consequence of this? In other words, how well does it bind?
I would say not so well.
Not so well. It's like okay,
yeah.
But it's not great.
That's not optimal.
Yeah. Remember, when basically the way that your immune system works is that you have to come up with B cell and T cell receptors before being exposed to any pathogen that could recognize any protein antigen in the case of T cells, or any antigen period in the case of B cells. You have to create a whole complement of these cells. So they're not going to be a perfect fit in the beginning. And so the relative affinity is low. And so that means that the antibody won't bind well to the antigen. And so Sujith, so how do B cells evolve to produce higher affinity antibodies? What do we call that?
I don't know.
Affinity maturation. So this is like a fancy way of saying that your affinity is maturing, right? It's getting better. Rosa, do you happen to know what exactly is affinity maturation?
Is it something with a BDJ recombination?
Close. BDJ recombination is really to make the B cell receptor in the first receptor. So affinity maturation, so most people don't know this, so let me explain. The basic idea is that you have an activated B cell that multiplies. Right? So let's say that this is B cell number 1. Right? It's B cell receptor. This is the antigen that it's trying to bind. Right? This is the pocket. It's going to bind, but not great. You can see this will fit, but it's not a great fit. In other words, the affinity is, so what happens is that I take this one B cell and I make many copies of it, each of which is going to have a slightly different B cell receptor. And so what will happen is that all of these B cells are now going to compete to try to bind to that antigen. And the ones that bind better are going to survive. And the ones that don't, let's walk through exactly what this would look like. So affinity maturation, where only the best binders survive. So again, we've got our B cell, number 1. This is the B cell that does not bind very well to the antigen, but it binds, as Zach said, it's a low affinity interaction. So the first step of affinity maturation is that you have many B cells. So now I'm just making 3 B cells, but it's probably many more than that. But let's just say that there's 3 in our example. So the B cell copies, there's many copies of the B cell. It all has a similar B cell receptor, but they're all a little different. So then now they're going to compete. They're going to see, hey, can I bind better? Can I bind better? Can I bind better? They're all going to try and bind to that antigen. So B cell 2 is going to bind. B cell 2 looks like it's going to bind the best. And then B cell 3 is way too narrow. No way that B cell 3 is going to bind. So then Jaya, what's going to happen? So the ones that don't bind well, what's going to happen to the ones that don't bind well? So B cell 1 didn't bind that well. So what's going to happen to B cell 1?
If I recall correctly, it would undergo deletion.
Yeah, exactly. Yeah, so it's not going to bind well. It's going to get kicked off from the interaction, and it's going to die. It will apoptose. Right? B cell 3, again, this B cell receptor, right, this variant of the original, is not going to bind that well. So it's also going to get kicked off, and it's going to die. So now we're left with the one B cell that binds the best. It's not a perfect binding, but it's certainly better than it was before. And so now what you do, so it's going to survive at least this round of affinity maturation, and then the process repeats. So now this will multiply itself. You'll have slight variations of its B cell receptor on each copy of the B cell that comes from this. And they will all compete and one of them will survive. And then the other ones are going to die. And then the surviving B cell or B cells are going to multiply until you have a B cell receptor that now binds really well to that antigen. Because what you're trying to do is you're trying to have that future antibody bind really well to the antigen. So the end result, again, if you're studying for step 2 and you're like, just get to the point, right? The end result is that the final antibodies after T cell dependent B cell activation are going to bind much better, right? So in other words, if I have a protein conjugate, or if I have a protein antigen, because the protein can be presented on MHC, and because that MHC protein complex can activate T cells, I can now have affinity maturation and isotype switching and memory B cells. But because of the affinity maturation, now the ultimate antibody is going to bind much. This is going to be very important because this will explain the phenomenon of warm agglutinates and why they're IgG. So this matters for step 2, so bear with me. So Gianna, so affinity maturation. So explain the process to describe why it's going to benefit a B cell. So why is that good for the B cell?
So the process I think that we just went over was affinity maturation, whereby like the B cells with the B cell receptors that have the highest affinity for the antigen are able to survive and undergo clonal expansion to duplicate itself. And so I guess it benefits a B cell because it makes it like more specialized to one particular antigen.
Perfect. Yeah. So the B cell receptor is going to bind with a much greater affinity, which means the future antibody is going to bind with a much better affinity. Yeah. And so Joni, so T cell dependent versus T cell independent B cell activation. So which produces higher affinity antibodies and why?
Would it be T cell dependent?
Yes, absolutely. So why would you get higher affinity antibodies with T cell dependent?
It's like how we were explaining. You need the T cell to be able to, that the process of generating antibodies. I'm sorry, I don't know how to really word this.
I know, it's hard. Yeah, it's hard. Yeah. Which is why I'm like, you'll see that a lot of these questions are variations on each other because I'm trying to build on it. Because I know that I'm taking slower steps along this because it's really tough. So I'm trying to go slow on this one. So yeah, so again, the idea is that because you have T cell dependent B cell activation, you can have affinity maturation, right? The whole point of affinity maturation is to make this B cell receptor fit better with the antigen.
Exactly.
And so ultimately, the ultimate product is that you'll have higher affinity antibodies for the antigen. So the punchline again is going to be that for something like warm agglutinins, which are IgG, they've undergone T cell dependent B cell activation, which is why, so they are higher affinity antibodies. So even when you warm them up, they are still able to bind to the. That's going to be one of the punchlines of it. I know it's tough. Yeah. So bear with me. So Satya, so what's the first antibody isotype that's made in response to an infection?
IgM.
Always IgM. Good. So what's unique about the structure of IgM?
It's a pentamer.
Yeah, mer I think means wall. So penta is 5. So great.
Yeah.
And so Melissa, if you're there, you can unmute yourself. If not, we'll go to Paula. So Melissa or Paula. So IgM. So use its unique structure to explain when it is made relative to other antibody types. So awkward question. So basically the idea is that because IgM is produced before the isotype switching, each of its 5 heads has weak affinity for its target, right? Because it makes sense, because by having 5 heads, I don't know, I guess it gives it a better chance to bind, more chances or like places to bind is sort of the way that I would think about it. This is sort of a hand-wavy explanation, but this is the way that I would think about it. So let's go to Sue. So what isotype is best for mucosal protection?
Right. So that's going to be IgA.
Perfect. And so T cell dependent versus T cell independent B cell activation. So which would be better for an infection against bacterial pneumonia, Sue?
Oh, so I would guess if it's IgA and you would need isotype switching, that would be T cell dependent.
Yeah, exactly. So ideally you would have isotype switching, right? So you could make IgA antibodies. So you could protect the mucosal surfaces, and you could have better protection against encapsulated bacteria. This is one of the things that like you'll see with the different kinds of polio vaccines. So Sabin, I think, is the live attenuated, and Salk is not. It's the inactivated one. So Sabin is actually given orally. I think you drink it. And so you actually make IgA antibodies for the live attenuated version because you're giving it basically against a mucosal surface. So it makes sense that you would make IgA antibodies. Versus Salk, still a protein antigen, but you will not get IgA antibodies. I think it's only IgG. So Deb, so what is agglutinin? What is it? What does that mean? So it's usually an antibody, but it can be an antibody, a lectin, or other substance that causes agglutination. I know, weird. So basically it's, again, usually an antibody that binds to an antigen and causes clumping. That's it. Because again, what we're trying to explain is what we mean by warm and cold agglutinins. Deb, so what do you think hemagglutinin means? So use its name, heme agglutinin. So use its name to explain what it causes in vitro.
It's a substance that causes agglutination of the blood.
Exactly. Yeah. So hemagglutinin is something that causes agglutination in the blood. It's also the name of a protein in influenza, right? So the H1N1, hemagglutinin is what the H stands for. But in general, it's a substance that causes clumping of blood cells. So heme. So in the case of influenza, it's the thing that binds to the sialic acid residues, which I didn't know. The reason why is because there's also sialic acid residues on RBCs, right? So it binds to the sialic acid. It's what allows it to bind to the respiratory epithelium, but it also will bind to the surface of RBCs, and that is ultimately what allows it to be internalized into the respiratory epithelial cells. So I was trying to figure out like what the significance is of the fact that, so it binds to RBCs. So what does that mean? Is that like beneficial to the organism? But it's not clear to me that it really benefits influenza at all to be able to bind to red blood cells. It is used, I found out that it is used in the clinical hemagglutination assays. So basically you can figure out how much influenza or pathogen there is based on the amount of agglutination there is. But yeah, it's not the main thing that you need to know for tests and for life is that this is the thing that allows it to bind to sialic acid residues on respiratory epithelium. The H allows it to bind to the sialic acid on the respiratory epithelium, and the N, the neuraminidase, allows you to cleave the sialic acid so that it can then leave, right? Because if you didn't cleave it, then any influenza virus that was to leave that respiratory epithelial cell is just going to bind right back onto the sialic acid because you've got hemagglutinin there that'll just bind to it. So you need something that will allow it to bind it first to get in, and then the neuraminidase is there to cleave it so the viruses can leave. Perfect. So antibodies. So in general, do antibodies bind better at warm or cold temperatures, and why?
I am not sure, but I would guess warm.
It's actually cold.
I don't know why.
Yeah, it's actually cold. So almost everything, if you go back to like chemistry, right? Virtually everything, including antibodies, bind better at colder temperatures. There's probably exceptions to this, but like in general, right? The warmer something is, the more kinetic energy there is, meaning the more they're moving around, the more kinetic movement there is in the molecules. So the colder something is, the less they're going to be moving around, which means the less that the molecules are going to be forcing themselves apart. So this is why, right? So their molecules are going to be closer to each other, so they're going to bind better. And so so when we say a warm agglutinin or a cold agglutinin, what is that actually referring to?
Antibodies that bind in a cold temperature versus warm, and in a warm temperature binding means even stronger affinity.
Perfect. Exactly. Yeah. So warm agglutinins really they're just an antibody that can cause agglutination at warm and cold temperatures. Because again, this is what always confused me at your stage, is I thought warm agglutinins, oh man, just not doing well with the spell check here. So warm agglutinins, I always thought that it was I thought it was like what we said, right? I thought that warm agglutinins would bind better in warm and less in cold. That is not true. Everything binds better in the cold. It's just that, as Vi said, warm agglutinins bind better, so much better than cold agglutinins, that even in warm temperatures, they can still bind. Whereas cold agglutinins are antibodies that can cause agglutination only at cold temperatures, but when you warm it up, they can't.
Alec, I have a question about that. So when it's cold, is that what you were showing, the IgM structure? You would want less kinetic energy because the IgM is like the pentamer, and so then they can bind easier in the cold? Do you understand
No,
that?
it's more just that, so I think it's unrelated to the fact that it's a pentamer, or at least you don't have to invoke the pentameric structure. The point is more just that in colder temperatures, that there is less kinetic energy, right? Because again, temperature is basically a measure of average kinetic energy. Go back to it. So yeah, so the colder temperatures, they're just the molecules, the antibody and the antigen are just moving around less at colder temperatures. So you're able to have binding more effectively. Because the more that they move around, the more you're going to break the bond between the two. So Grace, so which one would bind better than the other, and why?
We talked about warm versus cold. Would the warm agglutinins bind better because they have a greater affinity?
Yeah, and why would they have a greater affinity? What would they have undergone in order to have that greater affinity?
Do you mean by the selection process or just by sheer kinetics?
I guess both. So warm agglutinins have a higher affinity because they've undergone affinity maturation, that selection process where you have all the B cells multiply and then only the best binders. So Leah, so warm versus cold agglutinin. So use the meaning behind each name to explain what antibody isotype you would expect them to be.
So cold, I would think, is IgM.
Perfect.
And because we were just saying it has not undergone the affinity maturation, so you would not have anything except for the IgM, and then the warm would have IgG.
Perfect. Yeah, exactly. Because in this case, the fact that it's isotype switching is incidental, but it's an indication that you have had T cell dependent B cell activation. Good. Yeah. So off the warm agglutinins, right? So warm agglutinins, again, cause agglutination at both warm temperatures and cold temperatures. This is usually because not only have they undergone affinity maturation, but they've also done isotype switching. But the big thing is the affinity maturation. So often cold agglutinins, as you said, are IgM for the reasons that you explained. Perfect. So we're going to talk about the Coombs test next. So Sujith, So if you take RBCs, right? So I take someone's RBCs and they already have anti-RBC antibodies on them. And then I add the Coombs reagent, right? So this anti-human antibodies, right? So that would bind to antibodies. What will happen if I add antibody-coated red blood cells and anti-human antibodies? What will happen to those?
They'll agglutinate or clump.
Yeah, they clump. So this is what's known as the direct Coombs test, right? So you're taking RBCs from the patient and you add the Coombs reagent. And so Rosa, so for the direct Coombs test, if you see agglutination versus if you do not see agglutination, what does this mean? What does that indicate?
Whether there is presence of antibodies against proteins on the red blood cells or not, if there is agglutination.
Good. But let's be very clear, right? Because it's really easy and it took me years to understand the difference. So you'll have to forgive me for making sure that we cover this in more depth. So where are the antibodies? Are they in the patient's serum or are the antibodies already bound to the red blood cells?
They're already bound to the red blood cells.
Perfect. Great. So in other words, if you see agglutination, that means that the patient's RBCs already had antibodies on them. And all you had to do was add this little Coombs reagent, the anti-human antibodies, and that caused them to clump together. So the antibodies were already on the red blood cells. That's the critical thing. So if you don't get agglutination, the RBCs did not have antibodies already on them.
So why does adding the Coombs reagent cause red blood cells with the antibodies on them to clump?
You can understand it by like this. You can see the cross-linking, right? So the idea, again, I don't know how accurate this is molecularly, but the idea is that you've got like one FAB part can bind to one antibody and the other part can bind to another antibody.
Creates like little bonds between the red blood cells.
Exactly. You can see you're essentially creating like a bridge between these two.
Got it.
And so if you do that enough, right, you can create this clump of red blood cells. Great question. Yeah. You'd think like, why? Yeah, it's because these antibodies bind to human antibody. Great. We'll go to Zach. So Zach, what are the steps in the indirect Coombs test?
This one always trips me up. So
I know, me too.
Backwards. So I think you have, I'm just reading off of the picture as well. So you have this test tube filled with free antibodies to RBCs, I would imagine. And then
what are you taking from the patient?
Serum.
And why are you taking the serum?
You want to see if they have antibodies to RBCs.
Great. So this test tube is what you take from the patient, right?
Yeah.
Serum to see if they have antibodies in them already. Not antibodies coating red blood cells already, just the antibodies that could potentially coat red blood cells. And then you add what?
You add RBCs into that test tube.
Exactly. And then the next step is what?
So then you add the Coombs reagent, right?
Exactly. And then you see do they clump or not. So in other words, the first step is that you take the serum. So again, this is a critical difference, right? So in the direct Coombs test, you're taking literally their red blood cells versus in the indirect Coombs test, you're taking their serum.
Yeah.
And then the second step in the indirect Coombs is that you're adding red blood cells with known antigens on them. Usually you'll do multiple sets of these, but yeah. So you'll add red blood cells and then you'll add the Coombs reagent and then you'll look to see whether.
I have a question. So hypothetically they have the antibodies in their serum already. So if they have the antibodies, why are the antibodies free in the serum and why aren't they already on patients' RBCs?
Great question. Yeah. So you do this usually for this is like a type in screen. So so obviously you shouldn't have antibodies against your own red blood cells. That would not make sense. You would die.
Yeah.
However, let's say that you need blood. They have got this blood. It's ABO type match. So you're A positive and this blood is A positive. Let's just say.
All right.
If I give you that blood, maybe you have antibodies that aren't against the A or the B, right? Maybe you are ABO compatible. However, maybe you have antibodies against one of what they're called minor antigens, like KID, Kel, Duffy. Those are the big ones.
All right, thanks. I got it.
Yep. Yeah. So I want to know if I give you red blood cells, are you going to reject those red blood cells?
All right.
So great question. I didn't know this. I did a heme rotation at MGH. It was I was like, oh, makes so much more sense now. Yeah. So if a patient has anti-RBC antibodies and the RBCs have the antigen, then you'll see agglutination. So in other words, an indirect Coombs is positive if the patient has, they're called atypical antibodies. So atypical antibodies means antibodies against something that's not on their own red blood cells. So let's go back to Gianna. So Gianna, direct versus indirect Coombs. So use what you take from the patient to explain what exactly you are looking for.
So direct, you are taking red blood cells that already have antibodies on them to see if they agglutinate.
Sorry, you're taking red blood cells to see if they have antibodies on them.
Oh, because if they clump, then you know that they have antibodies on them. And if they don't, then you know they don't have antibodies on them.
Perfect, exactly. So that's the direct Coombs. So what about the indirect Coombs? What are you looking for?
So you're taking their serum, so you're trying to see if if you gave them a blood transfusion, if they would reject it.
So you're seeing, do they have antibodies against red blood cells, against known antigens on red blood cells? Not their own red blood cells, but against red blood cells in general. And again, like you said, the most common way in which you would see an indirect Coombs is a type-in screen. So if I'm thinking about giving you a transfusion, I will run a type-in screen beforehand, because I would hate to give you a transfusion and then you have a hemolytic transfusion reaction, get like trolley and die. That'd be bad. So Joni, direct versus indirect Coombs test. So when exactly would you perform? So we talked about the indirect. So when would you want an indirect?
Usually, don't you give these like for hemolytic anemias, like check for like for pregnant women?
Great. So direct, which would you do for a hemolytic? If you were working up a suspected hemolytic anemia, which would you do? A direct or an indirect test?
Indirect?
I guess you probably could, but the more smoking gun one would be the direct. So let me think better. So I didn't, this is a hard one because there's no reason that I don't even think I would have known this at your stage. So if you suspect immune-mediated hemolysis, you would do it. So in other words, if you suspect that someone is lysing red blood cells, either their own or someone else's already, in other words, you are, right? Because in other words, you have to think, when would I want to find whether antibodies are already bound to red blood cells?
Oh, right.
The time that I would want to figure that out is if I suspected hemolysis.
Correct.
If I suspected that they were already hemolyzing blood, either their own or transfused blood. That's generally when you do a direct Coombs test. Indirect Coombs test is to assess for antibodies against red blood cells, usually before transfusion or in pregnancy.
Right.
So these would be the most common, right? So a type-in screen and like the anti-RH antibody would be the most common indirect Coombs tests versus direct. Because again, there you're looking, do they have the antibodies? Well, that makes sense. So this is probably the most important thing for you guys to remember about the Coombs test is when would you use them? And this is also the thing that didn't make sense to me for the many years. So I know that I didn't explain that perfectly, probably not even. So what questions do you guys have?
I actually have a question about agglutinin factor. So I think in mycoplasma pneumonia, cold agglutinin is a test for that. I'm trying to figure out why would mycoplasma pneumonia cause cold agglutinin?
Yeah, that's a good question. I don't know is the short answer. I would imagine that it is because I think it has to do with their membrane. I would imagine that it's a similar enough membrane to red blood cells. So first of all, why is it IgM? Because it's not a protein antigen, would be my guess. So if it's not a protein antigen, you'll have IgM, and again, you won't have isotype switching. So there's something on the mycoplasma that is, so you're making antibodies against mycoplasma, right? That's the idea. And for whatever reason, it is cross-reacting. There's something that's similar enough on someone's red blood cells that it's cross-reacting. So it's probably not a protein, because presumably then it wouldn't be a cold agglutinin. So it's probably something else. I think that it's hypothesized that is like something in the membrane itself, which should be fat. I could be wrong. Does that make sense?
Dr. Palmerton, on the same question, is it safe to say that if it's a cold agglutinin, just by raising its temperature or something, you can inactivate its ability to agglutinate just from the warm, cold hypothesis?
Yeah, I agree. Yeah. So in other words, so I think what you're asking is like, when do cold agglutinin present?
Yeah, because mycoplasma pneumonia, it doesn't have the clinical picture as bad as the radiograph. So.
Oh, I think that's unrelated though.
Oh.
I think you are correct. That is true. Walking pneumonia. So atypical pneumonia is the walking pneumonia. So it gets that name because the X-ray looks so bad. You're like, oh my gosh, you must be so thick. And then what?
I'm just trying to think if it is literally temperature and if it can translate clinically or not.
I think so.
The cold agglutinin.
I don't.
Okay.
It'd be cool. That'd be cool. If you can make that connection, that'd be awesome. I love connections like that, but I don't see it as of yet.
So maybe you can just give a fever and the patient can just get better.
So we'll do a quick lab interpretation. What I'm going to ask is explain the relationship between the direct Coombs, the hemoglobin, and the bilirubin. Because again, we're trying to make essentially a pathophysiologic chronology from just the labs. Grace?
So the direct Coombs is positive. Are we suspecting possibly that they have hemolysis and that would be why they have an increased indirect bilirubin?
Oh, great. Yep. So direct Coombs tells you what? So if it's positive, what does that tell you?
If it's positive, that means that they have antibodies binding to the red blood cells.
Exactly. So that's like the smoking. That's like about as clear of evidence as you can get for hemolysis, like hemolytic anemia, or specifically like immune-mediated hemolysis. Great. So that would explain why you have an increase in your indirect bilirubin. Great. How about the hemoglobin? Can you explain that in context of the hemoglobin?
In context of the hemoglobin, we have a decreased hemoglobin. Usually we transfuse at around 7. That means that they are having their red blood cells they're having their red blood cells hemolyzed. So they have a decreased volume of hemoglobin.
Boom. That was great. That was really good. Wow. And to think, you're studying for step 2 and you can make these connections. That's good. That's great. Now, as Grace pointed out, right? So the direct Coombs is positive. That means that the RBCs are coated with antibodies. So again, in this context, it indicates that there's some sort of, doesn't necessarily mean it has to be autoimmune, but there's an immune-mediated hemolytic anemia that is leading to red blood cell destruction. That explains why there's low hemoglobin, but also, because again, bilirubin is the breakdown product of heme, which is part of hemoglobin. So that's also why there is an increase in the indirect bilirubin much higher than the direct bilirubin. Because all of the hemoglobin in your red blood cells is being, all the heme in the hemoglobin in your red blood cells that are being destroyed is being converted to bilirubin. Boom, that was great. All right, so we are back to our vignette. So I'm gonna have you guys revise your pathophysiologic chronologies to include as much detail as you can about all of the mechanisms. Again, go wild, because you won't necessarily do this in the real exam, but the more that you can connect these things and use the knowledge, the better it will be solidified in your mind so that you can use it next time. So let's go to the Google Doc, revise your pathophysiologic chronologies, and we will talk about it. Great, let's talk about that. Yeah. So let me walk through, because Vi, I think, had the same question, which is a good one. You're asking why is she tachycardic?
While also the blood pressure is kind of low.
The blood pressure is not necessarily that low. It's more the pulse is high. Let me read through and tell you how I would think about this first, and then we'll talk about so let me analyze the question. So I'm going to do like I did last time. So I'm going to analyze the question as if I was reading it to try to give you a sense of what you can expect or how to think about it. And then we'll talk specifically about the heart rate. If I don't answer your question, please tell me.
Yes.
So a 28-year-old woman comes to the physician with 4 weeks of worsening fatigue, dyspnea. So dyspnea is a little bit more specific. You can get down to system. So dyspnea is either a heart problem, a lung problem, or anemia. So between these two, again, like it could be a heart lung problem. So again, fatigue non-specific, it's probably still heart lung or anemia. That's 4 weeks. In a young woman like this, unless it's something really strange for heart or lungs, it's probably anemia. But you don't necessarily know. She's otherwise healthy. I would think probably anemia. But again, try to keep somewhat of an open mind. Her temperature, I don't know why, but maybe. Her temperature is normal. Her pulse is on the higher end of normal. Her blood pressure, I would just say is normal, right? It might as well be 120/80. The bigger thing that I'm looking at is the pulse. And her respirations are a little high. Again, neither are technically high, but they're the higher end of normal, like much higher end of normal. So that would make you think, again, non-specific, but if you're thinking anemia, that would make total sense. And we'll talk about the mechanism for why that is. The short answer is because there's less oxygen in the blood, I need to pump more milliliters of blood to my tissues to deliver the same amount of oxygen. So my cardiac output has to increase, right? I'm also going to have to oxygenate that blood more, which is why I would have to respire more. So on exam, she has pallor. So again, now you're thinking definitely anemia. Mild jaundice, which now you're thinking hemolytic anemia, because otherwise you shouldn't be increasing your bilirubin. And splenomegaly. So now you're really thinking hemolytic anemia. So now all these things fit, right? Hemolytic anemia, so I would be doing a pathophysiologic chronology in my head. Hemolytic anemia leads to destruction of red blood cells, leads to low oxygen content, leads to high output, leading high cardiac output to try to compensate. And because she can't perfuse her tissues as well, she's getting tired and dyspneic. Her labs basically fit everything that I would expect. Indirect hyperbilirubinemia, leukocytes are normal, hemoglobin's low, fits with hemolytic anemia, platelets normal, and her direct Coombs is positive. Again, telling me that there are antibodies coating my red blood cells. So that's basically it. That's how I would analyze this. Questions about that before I talk to you about the rationale for why she's tachycardic or her heart rate is higher than normal. So if I want to explain this well enough that you can understand this. If I don't, please tell me, because it means that I didn't do a good job of explaining it. So you may remember that the equation, I think I wrote this wrong before. It's 1.34. So oxygen content, right? The oxygen content equation is one of those things that you've probably memorized at some point, thinking like, why is this useful? You will never actually, I've never seen this actually used, like the actual number used, but the concept is very important. So this is the concept, right? So the concept is that in my blood, the amount of oxygen that I can carry is going to depend both on the oxygen that's bound to my hemoglobin. So this is the oxygen content equation, right? So 1.34 times hemoglobin concentration times the O2 sat. So you guys have probably seen this before. And so what this equation is basically telling you is that if you do the math, let's do the math, right? You'll never do this in real life. It's useful to do the math. So O2 content. It's useful to do this because it shows you like what the point of this equation is. So a normal PaO2, let's say, to make the math easy, is 100. And the normal O2 sat, we'll just say is 100%. So normally true. So hemoglobin, the low end of normal for a girl. So we'll just say 12. So if you do the math, if someone can do this for me. So 1.34 times 12 times the SAT, which is 100%, so 1, plus the PaO2, which is 100, times 0.003. Right? This is but let's be very clear. So when you do the math, can you do it so that the terms are separate? So because this is the O2 bound to hemoglobin is this term, and then the O2 dissolved in the plasma, this term, right, is the second term. So 1.34 times 12 is what? 15-ish? Great. So 15.08. Pretty large number. What is 100 times 0.00?
16.08.
Okay, so what is 100? So what is 100 times 0.003? It's about 0.3. Okay, so in other words, the reason why this equation is so valuable is not because the individual terms, or it's not because if you think this is 1.54, 1.74, 1.14, it doesn't really matter. Honestly, this term doesn't really matter. And memorizing that, 0.003, like if you forget it and it's like 0.006, it really doesn't matter because the amount of oxygen bound to hemoglobin, so Gianna, Vi, let's do Vi. So Vi, so how much, relatively speaking, right, how much oxygen is bound to hemoglobin relative to how much oxygen is dissolved in the plasma?
Yeah, a lot more.
Yeah, it's like many times more. So if I was so anemic, what if my hemoglobin dropped to half? So what if my hemoglobin was 6?
Yeah, it'd have a dramatic effect on the total oxygen delivery to tissues.
Yes, exactly. Yeah, exactly. What if I drove my P little AO2? What if I drove that to 600? What if this number increased by 6 times, right? I gave you a non-rebreather and just flooded your whole system with oxygen, but you're still anemic.
Right, because again, the hemoglobin bound oxygen, it's still orders of magnitude more.
Yes, exactly. So in other words, so in this case, this person it's roughly half, right? Their hemoglobin was 6.5, but for the sake of making the math easy, let's just say that it's 6, right? So in anemia, so in this patient, so in anemia, let's say the hemoglobin is 6. Now, the oxygen bound to hemoglobin is halved. It basically goes from 16 to 8, right? It's basically cut in half. So that's a dramatic change. That's basically half of all of, you can basically ignore this term. You might as well not even have that there. This contributes almost not at all. Almost all of it is hemoglobin. So Vi, what would happen? So now the amount of oxygen in my blood is now roughly half of what it should be, right? Now that I've been hemolyzing. So how much, if the demand for oxygen from my tissues is still...
Yeah, so cardiac output would have to double to compensate.
Perfect. Exactly. At least double, right? Because remember, as your cardiac output increases, the demand from your heart for oxygen is actually increasing as well. But it has to at least double, in other words.
So in this process, there isn't any baroreceptor involvement or decreased preload.
It's not from a decreased preload. Yeah, because remember, your blood volume isn't changed. You don't have to invoke, they're not necessarily hypovolemic. So if they stood up, they wouldn't necessarily be orthostatic. You can have, in blood loss anemia, if you were bleeding, you could both be hypovolemic and anemic. But anemia does not imply that you have to be. Does that make sense?
Yeah, thank you.
Yeah, absolutely. So does that explain then, does that answer your question then about why this person would have a heart rate that's a little bit higher than you'd expect?
Yes.
Yeah, because their oxygen content is lower. So therefore their cardiac rate has to increase because their demand for oxygen is going to be roughly the same, if not a little bit higher.
Along those lines, do you think that the increase or the doubling of cardiac output for anemic patients puts anemic patients at risk for left ventricular hypertrophy?
Oh, that's a good question. Oh, that's a really good question. I guess if it was chronic enough, maybe, but that'd be pretty chronic. I have never seen that. That is theoretical, maybe, but then you also run the risk of, with chronic ischemia, of having ischemia to the heart too. I don't know. If you showed me a case report of some woman that had to be bled to a low level and she was otherwise completely healthy and I would believe it. but I wouldn't necessarily go out looking for it. Other questions?
I just have one question. It's about when you mentioned the anemia doesn't and the hypovolemia part. I just didn't quite catch on that one.
Oh, sure. So anemia technically just means that you have a low hemoglobin. Hypovolemia means that you have a low blood volume.
Exactly.
But those are not necessarily the same. And I'll give you a good example in anesthesia. So let's say you lose a bunch of blood in the surgery. I could replete all of your blood with albumin or crystalloid, right? Like normal saline or something. So the amount of fluid that is sitting in your blood vessels is the normal amount of fluid. However, you could be very anemic, right? Your hemoglobin could be 4, but your total volume might be okay. Great question.
Thank you.
Yeah, I should explain that better.
Just one question.
Yeah.
In lines of like can you include in the pathophysiology chronology that there's a FAS mutation that causes the decreased apoptosis of the T lymphocytes, causing the T cells to produce antibodies against the protein of its own antigens?
So you're saying, so there are some autoimmune conditions that are hypothesized to be FAS, at least in some way related to FAS. Like I think Sjogren's maybe is one of them. You're saying could that be related? Could FAS be somehow tied into the autoimmune hemolytic anemia?
Yeah.
Maybe. I don't think so though, because remember, FAS is more T cell problems. So it's where T cells are attacking things that they shouldn't. And so normally FAS tells T cells to die, FAS ligand, whereas one of the mechanisms in which T cells can die or kill other things. Maybe. I don't know. I guess though. I actually don't know. If you told me, yeah, there's like a FAS component to this, there was like an interesting study that just came out in JAMA, sure, I'd believe you. I don't know that is true in this case.
No, if there's a mutation of the FAS?
It could be. I don't know that it is known what the etiology is. I personally do not know the etiology. I don't know that it is known though.
Sorry, I derailed this.
Other questions?
Can I just ask you one question about why the whole thing of when there is autoantibody production and then when the antibodies already bind to the RPC, what is happening with T cell signaling at this point?
I don't know that there is much happening with T cell signaling at this point.
Because in your pathophysiological chronology, you have develops antibodies against protein antigen on their own RPC, and then T cell dependent T cell activation, affinity maturation, and IgG. So I'm thinking, is that the process behind the autoantibody production, or what is the link between the two?
So in other words, there's some antigen that's somehow activating T cells and B cells together.
Yeah, when there are already antibodies that are binding to the RBC, why are the T cells involved at this stage?
Oh, you're saying this should probably be...
Yeah.
You're right. That's a much more elegant way of saying it. The actual chronology of it's a little off. You're right. That's a little strange. So really, I would say unclear etiology. So immune activation against protein antigens on your own red blood cells. So that somehow you get T cell dependent B cell activation. That would lead to affinity maturation and isotype switching. And then you would that's how you can get IgG. Is there a clinical difference between cold agglutinins versus warm agglutinin AIHA? Vi is asking. In symptoms, yeah. So typically, autoimmune hemolytic anemia typically is more warm agglutinins, which kind of makes sense, right? Because they're going to be higher affinity antibodies. I think cold agglutinins, if they do present, typically it is actually in the cold. So it's extremities. If you get cold, it'll happen in if you get like cold extremities. So I think that this actually does play a role in the actual presentation, right? That if you keep warm, you are less likely to get hemolysis from cold. Yeah, great question. So this is the summary of key concepts. In the interest of time, you guys can rewatch the first part of this to go over the summary of key concepts, or you can just look at this. The thing that I will emphasize, though, is the direct Coombs, right? So again, remember, in direct Coombs, basically you're looking for hemolysis, right? You're looking for evidence of hemolysis. So red blood cells that are already coated with antibodies. Whereas in indirect Coombs, you're looking for the presence of antibodies. So the classic one would be type and screen, right? Before you're going to give someone a transfusion of someone else's red blood cells, you want to see, do they have antibodies that could bind to those red blood cells? The other one would be RH, to see for moms. Do they have RH antibodies that could attack the baby? Well, thank you guys very much. So I know that we've gone over this now 2 times, but I want to do it, or 1 time. But I want to do it again just because it's really important for what we're going to talk about. So I'll probably include this in the Google Doc so that you guys can see it. But I'm just going to have this here so you see again, LFTs, not tests of liver synthetic function, even though they're called liver function tests. So bilirubin, as a reminder, is a breakdown product of heme. Direct is conjugated, indirect is unconjugated, right? It explains a lot of the things like the color of poop and pee, also the color of bruises and other things. AST and ALT are basically, they're enzymes found within hepatocytes that are only released or mainly released if you have hepatocyte damage or death. So that's the main reason why AST and ALT are elevated. Alk Phos is the main reason is actually because of an increase in synthesis, right? So this will become really important because we're going to talk about all of the LFTs and the patterns today. And because you'd think that if it was just because of leakage from damaged cells that AST, ALT, and Alk Phos would all be up in the equal amounts, but they're not. And it's because they're elevations for different reasons. AST and ALT are mainly because of damage. Alk Phos is mainly seen in biliary stasis because of an increase in synthesis. Right? Obviously, AST, ALT, and Alk Phos are found in other things that are not just hepatocytes. Alk Phos is the one that you really should know about, although AST is also found in like muscle and stuff like that. But Alk Phos is found in bone, liver, and placenta, among other things. And as a reminder, for acute liver failure, the most common ways of measuring synthetic function, there's a couple others other than PT and albumin, but the most common ones are PT and albumin. So acute liver failure, PT is up, albumin's normal, and then chronic liver failure, PT is up and albumin's low. That has to do with half-lives. So with that in mind, I want to go to our question. So a 25-year-old male has a 1-week history of fatigue and nausea with a 2-day history of skin yellowing. His past medical history is unremarkable. He denies any alcohol, tobacco, or illicit drug use. He works in a local restaurant. His temperature is 37.8, heart rate is 90, blood pressure is 115/78. Physical exam is significant for jaundice. His liver is slightly enlarged without tenderness. Abdominal exam demonstrates no spider angioma or fluid wave. What is the pathophysiologic chronology? So his labs, you can see, are bilirubin total is 6.2, direct bilirubin is 3.8, Alk Phos is 200, AST is 1221, alanine aminotransfer, so ALT is 1349. PT and albumin are normal, and he's got positive anti-hepatitis A virus IgM, negative HIV IgG, and he's got anti-HBs antibody, which is positive, and then anti-hepatitis B core antibody, which is negative, and negative hepatitis B surface antigen. So I want you to walk through the pathophysiologic chronology. So let's go through the pathophysiologic chronology. So the summary would just be that he's got from fecal oral transmission, he's got an acute hepatitis A infection that leads to, we'll talk about the different patterns, but a very clear hepatocellular LFG pattern, sometimes called intrahepatic. So that's why because it's an acute infection, that's why it's IgM and not IgG. He's got inflammation of the liver, which we'll learn anytime you have inflammation of the liver or basically the gut tube or any of the derivatives. So liver, gallbladder, appendix, or pancreas, you can get nausea. It's possible to get nausea. And so we'll talk about the detail later, but that's the big picture sort of summary of what's going on. So our summary of key concepts. So the main thing that we're going to go through today is to talk about the different patterns that you see for LFT abnormalities, because this comes up a lot. And so there is a more intuitive way of thinking about it, which is to think about it very similarly to how you think about like kidney failure. So you can think of it just like there's pre-renal, intrarenal, and post-renal. There's also, you can think about it for jaundice especially, you can think about it in terms of prehepatic, intrahepatic, and posthepatic. It doesn't work quite as well as it does with the kidneys, but it works like 90% of the time, which is pretty useful. It's a pretty intuitive way of thinking about it. I am going to include, however, the more common way of describing LFT abnormalities, which you'll see more in textbooks. And certainly that was what we learned at Stanford and what they did at MGH, which is thinking about it in terms of just recognizing the pattern. So isolated hyperbilirubinemia, which is kind of like the prehepatic, hepatocellular, which is essentially like the intrahepatic, and then cholestasis or cholestatic, which is basically your posthepatic. So there's a lot of overlap between them, which is why I included them in one. Sometimes you'll also see infiltrative, which I didn't include, but that's basically where you see just an increase in Alk Phos and none of the others. So the other thing I want to talk about is a way of thinking, a systematic way of thinking about nausea and vomiting that is, I think, really helpful. Because when I was at your stage, it was really hard for me to think about nausea and vomiting because I was like, I don't know, like, can esophagitis give you nausea? What does that tell us? What does it mean? So the punchline is going to be that anytime you have obstruction or anytime you have inflammation of a gut tube or one of the four buds, so the pancreas, liver, appendix, or gallbladder, it can, not always, it can lead to nausea and or vomiting. Obvious caveats are that not all causes of nausea and vomiting are GI related, right? You can obviously get GI. There are lots of causes of nausea and vomiting, which we're not going to talk about today. We're just going to focus on the GI causes, but it's useful to know what are the things that can cause nausea and vomiting from the GI. It's also important to note that the lack of nausea and vomiting does not rule out GI causes, right? So if you don't have nausea, it doesn't mean you can rule out like hepatitis. That said, it is still a really useful way of thinking about nausea and vomiting. It's also really useful because you can use this as an analogy to think about coughing. Because again, I always had a really hard time of thinking like, what would cause coughing? What's a good systematic way of thinking about coughing? And so in the same way that obstruction or ultimately pressure or inflammation of the gut tube or its derivatives can cause nausea and vomiting, basically the same thing in the respiratory tract can cause coughing, right? If you increase pressure on the wall of the respiratory tract, so a bronchoscope, something where you're looking into someone's lungs and you brush the side of the wall, they will cough like crazy. I can tell you that. Personal experience. And inflammation, also the same thing, right? Like, why do viral illnesses cause so much coughing? Asthma. Why do steroids help with reducing coughing, right? It's basically the same idea. All right. And with that, we will get started. All right. So our systematic approach. So as a reminder, there are two most common causes of approaches for LFT abnormalities and for jaundice. So again, the most common is to look at just the pattern recognition. So you'll see hepatocellular, isolated hyperbilirubinemia, cholestatic, and then sometimes invasive. It's essentially high alk phos, but everything else is close to normal, including the bilirubin. So it's sometimes included, so I describe it just so that you know, but it's not that common. So bilirubin, the more intuitive way of thinking about it is to look at causes of jaundice. So causes of jaundice, one schema is to say prehepatic, intrahepatic, or posthepatic. So they're essentially interchangeable. And so in the hospital, you'll probably hear this more often, but in your head, oftentimes I think it's actually more useful to think about in terms of pre and post. But I included both so that you can rock both the intuition as well as frowns. So let's go to Paula. So Paula, prehepatic versus intrahepatic versus posthepatic. So using your knowledge of bilirubin, explain which would have the highest direct conjugated bilirubin and which would have the least if it was pre, intra, or post.
The highest conjugated posthepatic.
Perfect. Yeah, exactly. And why does that make sense?
Because when we're talking about posthepatic, we are saying cholestatic. So then if we have a problem, if the problem is not in the liver, so we're going to be able to conjugate the bilirubin. So from indirect to direct.
Exactly. Yeah. Great. So posthepatic is going to have the most. Sorry, I shouldn't show it to you. So which is going to have the least?
Then it's going to be the prehepatic.
Good.
Yeah.
Yeah. So post, right? Because the liver is fine in posthepatic, right? So you can conjugate just fine. The problem is that the conjugated bilirubin, for whatever reason, cannot make it into your GI tract. So there's cholestasis, right? So that would have the highest conjugated bilirubin. Intrahepatic is going to be in the middle. So you're in the process of conjugating it. So you're conjugating some of it, but because of damage to the liver cells themselves, you're going to have spillage of bilirubin from inside the hepatocytes. The prehepatic, there's the least direct bilirubin. You are increasing the production of unconjugated bilirubin in most of these cases. The other cases of isolated hyperbilirubinemia would be like what we saw before with Gilbert, where the problem is that you just can't conjugate it. This is why it's not quite as perfect of a schema as it is to say pre-renal, intrarenal, post-renal, because it gets a little messy to say like prehepatic for things where it's like it's a problem with conjugation. Is that it's a problem with the liver, but it looks like the prehepatic. So that's why I think it's probably not quite as common, because it will not cover 100% of the situations. It is more intuitive though, which is why I included it. So prehepatic versus intrahepatic versus posthepatic jaundice. So using your knowledge of bilirubin, explain which would have the darkest urine and which would be the least dark. All right, we'll move to Matan. So Matan, what do you think?
So we look at the solubility or the polarity of the molecules. So direct bilirubin is polar, therefore it's not bound to albumin, it's freely filtered, it'll end up in urine will be dark. Unconjugated or indirect is non-polar, it's bound to albumin, not freely filtered, it won't darken the urine.
Boom. Yeah, exactly. So in other words, the posthepatic is going to have the darkest urine. Absolutely. And it's for exactly the reasons that you said, because the direct bilirubin will be soluble in the water, and so it can actually enter the urine. And so that's why posthepatic is going to have the darkest urine. Intrahepatic, again, is going to have the middle. It's sort of like Goldilocks. It's going to have the middle amount of conjugated bilirubin, so it's going to have maybe a little bit of dark urine, but not too much. And then the prehepatic is going to be mainly unconjugated bilirubin. So less than 20% of it's going to be conjugated. And so that is going to be largely not dark urine. It is almost never dark. Great, or at least from the bilirubin itself. All right, so Joni, so using your knowledge of AST and ALT, which would have the highest levels?
So AST and ALT are indicative of intrahepatic. Would it be?
Yeah, great. Yeah, so they're highest in intrahepatic. Great. And why?
It's AST and ALT are indicators of hepatocellular damage.
Yeah, they're enzymes that are found within hepatocytes. If you have damage to the hepatocytes, they'll be high. Great. And so great. Exactly. So post-hepatic might have a mild elevation, right? Oftentimes you'll have a little bit, which is why I think people get confused, because there will still be some elevation even in post-hepatic, presumably because you still get some damage from cholestasis if you get backup of bile, although it's not nearly as much as it is in intrahepatic. So pre-hepatic has virtually no elevation. So the reason why it's called isolated hyperbilirubinemia is because that's basically all you see. All you see is the increase in bilirubin that is indirect. All right, Grace. So using your knowledge of ALK-Phos, which would have the highest levels?
So would you say, would it be post-hepatic?
Yeah.
See, I know that increased ALP is associated with cholestasis. I'm trying to remember.
Yeah, it's not super important to remember why. There is an increase in synthesis, right?
Right.
So the reason is because of an increase in synthesis. The reason why I include that, as opposed to just memorizing this, because it helps explain why because it is actually an enzyme that is found within hepatocytes. So you would think that if you damage hepatocytes directly, that ALK-Phos should increase the same amount as AST and ALT. But the reason why it's not is because the major reason why ALK-Phos goes up is because of an increase in making of ALK-Phos. And that happens for whatever reasons that are unclear to me, when you have cholestasis. So it's interesting. It's not, at least in the papers that I read, we don't know what ALK-Phos does in what the major purpose is in the GI tract. So there is a small elevation, right? So it's the opposite of the AST and ALT, right? So for hepatocellular, you have a lot of AST and ALT and a little bit of ALK-Phos. For the post-hepatic or cholestasis, you'll have a lot of ALK-Phos and a little bit of AST. A lot of ALK-Phos, a little bit of AST, ALT. So pre-hepatic, again, it's isolated hyperbilirubinemia. You don't really see much of any of the ALK-Phos. So sometimes you will see something called R factor. So let me tell you what R factor is. I don't think that it's one of those things that you should memorize. I think the concept is more valuable. So I want to talk about this. It was actually in the white book for MGH for like the interns that talk about like LFT abnormality. So it is used sometimes, but I think the concept is probably more valuable because I think people still get really confused about like how to recognize these patterns. So our factor in the equation is ALT over ULN, which is the upper limit of normal. Sometimes you'll see ULN. So ALT over the upper limit of normal divided by ALK-Phos over the upper limit of normal of ALK-Phos. So the major downside to this, because you may be wondering, because you'll see ULN sometimes, like for example, in like Light's criteria or the Light criteria, you'll see upper limit of normal for looking at, I think, total protein, or no, albumin. I think it's albumin. And so like you might wonder why is this not a fixed number? It's because the upper limit of normal varies by the hospital. So I looked up what the upper limit of normal was for the USMLEs. So for ALK-Phos, it's 70, and for ALT, it's 20. So if you do the math, right, if you flip this around, right, so the upper limit of normal, right, so you're dividing by something you're dividing by. So if you flip this, right, the upper limit of normal of ALK-Phos and do the math, right, so the upper limit of normal of ALK-Phos ends up on top, and the upper limit of normal of ALT ends up on the bottom. And so if you look at the ratio of these, it ends up being 3.5 for the USMLEs. Again, for your particular hospital, it will be different, but for the USMLEs, I did the math and it's 3.5. So what would be then, if you followed this, and then I don't think I did a very good job of explaining it, so probably couldn't follow this, but we'll see. Sujith, what would be a quick and dirty way to calculate the R factor? Right? So ALT over the upper limit of normal divided by ALK-Phos over the upper limit. So what would be a quick and dirty way to calculate it? And what does it tell you?
ALT by ALP.
So it would be, so R factor is ALT divided by ALP times 3.5. So in other words, all of this times 3.5. Right? So this is written with the correct order of operations, but I just want to make this really quick. So in other words, if R is above 5, that tells you that it's hepatocellular. If R is less than 2, that tells you that it's cholestatic. And so again, this quick and dirty way really is only like USMLE specific. It will vary depending on the hospital. Are we I have some examples of this. So I want to show you how you can use this and why it's valuable. The reason why I am even bringing up R factor in the first place is because just to say, because you'll see tables like this where it's, oh, what's most prominent? So AST is most prominent in the intrahepatic. Alk-Phos is most prominent in posthepatic. If that's with you, you don't really have to worry about R factor. It's more when they're both elevated and you're like, gosh, I don't know. What's more elevated than normal? Geez, I don't know which is most prominent. That's where R factor comes in. And also to tell you what's mixed, because if it's between 2 and 5, that tells you that it's a mixed pattern. So Sujith, let's say that the ALT was 900 and the Alk-Phos was about 300. What kind of LFT pattern would this be and why? Those were the only two things you knew. Could you calculate the R factor and tell me what the LFT pattern?
It will be, are you asking if it's hepatocellular or pre-hepatic? This is hepatocellular.
Great. And how did you come to that?
It's more than 3.5. So 3 into 3.5 is around 10.
Great. Yeah, perfect. Exactly. So you can do it one of two ways, right? You could do it like Sujit said, where you like eyeball the R factor and see is it 5 or less than 2. That was the point of this question. But if you are comfortable just saying, well, ALT is like really high, Alk-Phos is just like a little high, that's also okay. Honestly, that's how normally I go about this. Right? It's just that that's a lot harder to communicate to someone else. It's a lot harder to teach someone. Say, oh yeah, just like eyeball it and say, oh yeah, Alk-Phos is a lot higher than normal, or ALT is a lot higher than normal, and Alk-Phos is just a little bit higher than normal. That I think is harder to do, especially if you don't have a lot of experience looking at LFTs. So if you're not comfortable with that way, then R factor is for you. So you can think about it as the elevation of the ALT is much more prominent, but to be more precise, you can do what you just did, which is to say ALT over Alk-Phos is about 3, right? And so 3 times 3.5. So this is USMLE specific, 3.5. So 10, so that's a lot more than 5. So this would be hepatocellular. Cool. All right, so we are going to practice this more. Do you want to take a shot? Oopsies. Want to take a shot at this? So what pattern of LFT abnormalities is this, and what condition is most likely?
Would we first look at, I guess, the ALT? So that is going to be 1349. And then I guess that would be high. And so with the ALP at 200, so let me do that real quick. And then multiply that by 3.5, right? So 23, which is greater than 5. And so that would signal me towards an intrahepatic.
Perfect. Yeah,
Okay.
exactly. Yeah.
Cool.
So I think that's the easiest. So again, so the other way of doing it would be to say what?
The other way would just be like looking at ALT is much, much higher than ALP.
Yeah, or just to say, yeah, exactly. Or just elevated over normal is much higher than the amount that Alk-Phos is elevated over.
What was the normal value again for the two?
I think 70 is Alk-Phos. Upper limit is Alk-Phos. The thing to remember is Alk-Phos is a bit higher than ALT. So I think it's 70 for Alk-Phos and then 20 for the USMLEs for.
Okay, yeah, that's a part that I wasn't familiar with. But yeah, that calculation is actually like much more straightforward for me. So that's cool.
Good. Again, I include both just to give you guys like a sense. I should be completely upfront with you. I don't use R factor. I just eyeball it and say, man, this is a lot higher than this is like real high. This is a little high.
Right. Having that frame of reference for sure. But having the equation to calculate it out for me like that, it was a lot easier.
I figured, it was good. In fairness,
Cool.
The other thing is that you can also use the percentage of the bilirubin, right? So the direct bilirubin is a little less than 50%. So that's also very characteristic of an intrahepatic or hepatocellular pattern.
For sure.
Cool. So I included all of these so that you can be really clear. And again, let's be honest. It's patients, the real world, even the tests, they're not going to have necessarily read these textbooks. Like sometimes maybe the direct bilirubin is going to be more than 50%, a little bit more than 50%, or that's like the major one. Sometimes like this doesn't fit quite as perfectly as you'd want it to, but go with the thing where most of it's going to make sense.
Right. I think honestly, like when doing like practice questions and using this approach, it'll help the application part of it be a lot easier.
I think so. And so again, this is why the IgM is positive, but there's no IgG because it's a acute infection. All right, so Saba, how about this? So walk us through. So again, I want you to use as many of the different, because we want to practice this. For these purposes, I want you to use as many of the different ways of determining what LFT patterns it is. Yeah, so go for it. I've only given you one, I guess. Saba, are you there? You have to remember to unmute yourself.
Oh, sorry. Yes. So in this case, because the indirect bilirubin, which I calculated
from total bilirubin minus direct bilirubin, that would be 5. Because the unconjugated bilirubin is higher, that would make me think that it's a prehepatic. Because, yeah, if you haven't made it to the liver to get conjugated yet, then, yeah, you wouldn't expect.
Now look at the other labs, because again, I give you a ton of clues here that they weren't AST, ALT, alk-phos, but I give you a ton of clues. So why is there an isolated hyperbilirubinemia in this case? I'm looking specifically at the hemoglobin and the direct Coombs test. You may not have been here last week.
No, I wasn't, unfortunately.
Okay, that's okay. So I'll pick on someone else. Zach, you're taking your test real soon, so let me hear it.
All right, so direct Coombs test. So you have second autoimmune reaction. You have antibodies against RBCs. They break down the RBCs. And they break down the RBCs. And in intravascular, like hemolytic anemias, your indirect bilirubin is going to be high, and your hemoglobin is obviously going to be low. So you're shredding RBCs.
So interestingly enough, intrahepatic, actually extrahepatic is more associated with high bilirubin.
Did I say intrahepatic? I meant to
intravascular.
My bad.
And that's because, and let's be clear. So the reason is because if you have intravascular hemolysis, if you have shearing from DIC or HUS or something like that.
Oh, okay, yeah.
You don't have, the hemoglobin is free floating.
Yeah, that's
It hasn't had time, the macrophages haven't had time to just consume it, turn it into bilirubin.
Yeah. So should I rephrase this as like when you have an autoimmune hemolytic anemia, then your indirect bilirubin is going to be high?
Yes. Yeah, exactly. Yeah. Perfect. Because what question are you answering? What is that?
So like why is,
what question exactly are you answering with the direct Coombs test?
So you're answering, do you have antibodies against the RBCs? Is that what you mean?
Yeah.
Or antibodies against
the question is, did immune-mediated hemolysis happen already?
Okay, yeah.
Versus the indirect is basically saying, could you have?
Potentially have it if you added RBCs.
Like, do you have antibodies that could cause?
Yeah, this is like what we did last week.
Yeah, exactly. Perfect. Yeah, exactly. So that's why. So in other words, so you've got autoimmune hemolytic anemia, right? And so the pattern is, prehepatic, right? So isolated hyperbilirubinemia. So and the way that you can tell is that there's the D-bili is low, and I didn't include the LFTs, but the other ones would have been normal. And so again, the direct Coombs is telling you the RBCs are already coated with antibodies. In other words, the question that you're asking is, did hemolysis already happen?
Yeah.
Perfect. All right. So let's go to Mary next. So Mary, what pattern of LFT abnormalities is this? And what condition is most likely? All right, we'll go to Deb. Deb, what do you think?
So there's elevated alkaline phosphatase, and so the ratio of ALT to alkaline phosphatase is less than 2, and so this is a post-hepatic pattern.
Great. What else can you use to help? Okay, so that's good, right? So you said alk-phos is really high, ALT is not that high. And if you were to do the R factor, then it's less than 2, so great. So that would be post-hepatic. What else can you look at to argue that this is post-hepatic?
The direct bilirubin is high.
Yeah, exactly. It's mainly direct bilirubin. Great. And if you want to quantify it, it's 80%, much more than 50%. Great. What condition is this? Now we got to put it together, right? So there's 2 parts to lab analysis, right? Like you got to say, what's the pattern, right? But you also have to look at the bigger picture and say, what exactly is going on?
There's leukocytosis, and the CBD is dilated. Is there any cholelithiasis or?
Yes, there is. Where is the stone? Where is the stone located? And why is the leukocyte high?
The CBD is dilated, so the obstruction site, is it cystic duct or CBD?
Yeah, it's got to be the CBD, because if it's in the cystic duct, your common bile duct should not be dilated. Why is the leukocyte count high? Why is the white count high? It's pretty high. 22,000 is high.
There's a leukemoid reaction due to infection or inflammation.
Very good. Exactly. Yeah. So this, I was trying to show cholangitis. Yeah. That would be the easiest way to look at, to explain all of these things. You've got really high alk-phos, mild elevation of the AST/ALT, and really high D-bili relative to the total bilirubin. Your white count is really high and you've got a dilated common bile duct. This would be very concerning for ascending cholangitis. So your direct bilirubin would be, so we talked about this. So the pathophysiology, just to be very clear, so you've got gallstone from the gallbladder that lodges in the common bile duct. So the common bile duct pressure is going to increase for whatever reason, probably because of pressure ischemia. You will have bacterial translocation, right? Because there's bacteria that's just present in the lumen. So they can infect the wall. And as they infect the wall, that infection can ascend. So that's how you get cholangitis. That's the basic idea of getting cholangitis. So the bacteria, it's really easy then to enter the bloodstream. And so that's why you can get such a profound leukocytosis. So this would be pretty is pretty scary, pretty severe, or potentially pretty severe. Questions so far? So we just covered the LFT patterns and did some practice, as well as giving you various different ways of thinking of differentiating between the different kind of patterns. Questions so far before we talk about nausea, vomiting, and then make an analogy?
Alec,
Yeah.
it's Metan here. On the slide before, so what is that actually heading towards Raynaud's planted where you get the hypertension and the altered mental status because you're basically almost in septic shock?
Yes. Oh yeah, exactly. I think that is why. Yeah.
Cool.
I think that's why you get, because it's basically, it's basically septic shock. Yeah. You hyperperfuse your brain. So you can get.
That's nice. I never knew why. I always knew that it happens, but it's nice to connect the dots.
Yeah.
Cool. Thanks. Yeah.
I have a question, Alec. Would your PT be elevated in that last scenario if it was like really bad and the white count's not like insanely high? It's not like 70,000, but could your PT be,
I guess though, probably not though. No, probably not. Could it happen? Sure. Absolutely. Yeah. But I don't, because you'd have to say that there's a liver failure. Is there a liver failure? I mean, it could, in theory, sure. Any infection, any form of septic shock could, in theory, give you liver failure. So if you showed me a picture where like the PT was elevated, could I see a conceivable mechanism how they could have had liver failure? Absolutely. But could you rule out ascending cholangitis because their liver synthetic function is normal? No. Does that make sense?
Yeah. Thank you.
Yeah. Great question. Fantastic question. All right. Other questions?
Sorry about that. It's a question about septic shock one. The reason why we said septic shock, is it because of increased leukocyte count?
Oh, sorry. You caught me. Technically, septic shock is, so the definition of septic shock is actually that you've given enough fluids and they still don't respond to fluids and you need pressors.
Right.
So we don't actually know that they have septic shock here. So I guess technically what I think Matan and I should have said is to say that shock, in other words, insufficient perfusion of your end organs, which in this case, the organ we care about is your brain, right? If you're trying to describe why someone with sepsis could have like encephalopathy or altered mental status, shock could explain why you have altered mental status. But technically, based on these labs, you do not know if this is septic shock, right? Technically, you'd have to say like severe sepsis.
Correct. Yeah.
I like it. Yeah. Gotta keep me honest. Precision with language. Thank you. No, that was really good. Matan? Yeah, absolutely.
Alec, what's the reason that bilirubin or hyperbilirubinemia causes pruritus?
Oh, interesting. So it's not that bilirubin, my understanding is it's not the bilirubin itself that causes, it's a correlation, right? It's BUN increased. People that have high BUN can get like uremia. It's not because the BUN itself, it just correlates with it. I think the same thing is true with bilirubin. My understanding, the way that it was explained to me is that it's because of the bile salts, right? So bile salts emulsify fat, right? So they help basically dissolve and increase the surface area of fat. So that can get into your skin, into your fat. So my understanding is that the pruritus comes from the bile salts itself, not bilirubin. Yeah. All right. So let's talk about some nausea and vomiting, right? The punchline is going to be that nausea and vomiting for the GI tract and cough for the respiratory tract are both confusing, but at least there is an intuitive way of thinking about it. There's a sort of a systematic way of thinking about it. And before we do that, we're going to talk about the gut tube. Zach, what are the derivatives of the gut tube?
Yeah, so derivatives of the gut tube comes from endoderm. So you're going to have your pancreas, liver, appendix, and stomach.
What else?
And then your intestines. So small intestine, large intestine. Yeah.
Perfect. Yeah, basically everything from like your esophagus all the way down.
Yeah.
Like,
sorry, those are the gut buds, right?
Exactly. Yeah. The systematic way of thinking about it is like your entire GI tract from your esophagus all the way to the upper part of your anal canal, right? That entire length of bowel esophagus. Plus the 4 buds that attach to the GI tract, the butt off bit, pancreas, liver, gallbladder, appendix. Great. And so Feluke, can obstruction of the gut tube or its buds cause nausea/vomiting, and why?
Yes, it can, since there's going to be pressure.
Yeah, exactly. So there are mechanoreceptors, right, that sense pressure, as you said, in the GI tract wall. This forms the afferent signal to the vomiting center in the brain.
Alec, I have a question.
Please.
Is there a serotonin associated with this? Because I was just doing a UWorld question about how you give on like a serotonin blocker for anything that causes like irritation.
I think it's actually, so like ondansetron, I think is actually a central mechanism.
Oh, okay.
Yeah, the H3, I'm pretty sure is a central mechanism. I'm pretty sure serotonin is not involved in the afferent signaling. I could be wrong. but I'm pretty sure that's a central mechanism. Because again, the reason why I say that is because ondansetron works for things that aren't just GI related. So like postoperative nausea and vomiting, that's like the most common drug is to give Zofran.
Oh, I see.
All right. Good question. Right? Again, this is why it's confusing. So what I'm trying to do with this nausea vomiting portion is to elucidate one aspect of a very confusing topic. Right? Nausea vomiting is very confusing. Like many things can give you nausea and vomiting. I'm not trying to explain everything that can cause nausea and vomiting. I'm trying to explain the things, like a systematic way of thinking about the GI causes of nausea and vomiting. So to hopefully make it more tractable. So Vi, what effect generally does inflammation have on nerve excitability?
Inflammation, doesn't it increase the excitability?
Yeah, it does. Yeah. So I went really deep down to this rabbit hole, but I can tell you, I can summarize basically by saying that inflammation generally causes both the nerves and the nerve receptors to be sensitized. So again, that's a huge field of research. I was shocked at how many papers and things, like stretching back decades. But generally, this is true. So if you are interested, some of the more representative findings would be prostaglandins increase mechanoreceptor sensitivity. Inflammation also causes an increase in sensitization of nociceptors. There was also these really interesting studies where they looked at why inflammation can cause nerves themselves to become sensitized. Like nerves generally don't respond that well to touch. They don't respond that much to like touch. However, in inflammation, they do, and there's like interesting mechanisms for why. But the general way for your stage in general, right? I think the best way to think about this is that inflammation causes nerves and nerve receptors to become more sensitive. Leah, in the GI tract, what effect does inflammation seem to have on nerve excitability? How can you use this to explain the symptoms of things like inflammatory bowel disease, like Crohn's or UC?
Okay, so if we're saying that inflammation increases the nerve excitability in the GI tract, then in something like Crohn's, that's a chronic inflammatory state. So you're like chronically having the vagal afferent nerves in the GI tract like constantly stimulated. And so you're going to get like probably nausea and cramping and that sort of thing.
Yeah, nausea, cramping, diarrhea. So inflammation leads to sensitization to distension, right? There's a number of papers on this. If you want to look at the PubMed IDs, this is what they are. So the thought, I didn't really know this, but the thought for why like IBD happens, or one of the thoughts for like why the symptoms of IBD happen, is that you get chronic inflammation. So that causes you to become more sensitive to distension. So remember, distension is the signal for the gut to move things through, right? So that's why you give like bulking agents. That's why fiber, right, makes you have to go to the bathroom. It's because you can't digest, well, it's insoluble fiber, right? You can't digest insoluble fiber and it's bulky. And so it distends your gut, and your gut senses the distension, and it causes contraction of the GI tract and causes the peristalsis. And so one of the very common symptoms of IBD and inflammation of the gut in general is tenesmus, right? The feeling like you have to poop, but you're not able to, like, you still have to poop, but like nothing's coming out. And then another symptom that's really common is diarrhea. And so a really tantalizing explanation for that is to just say inflammation sensitizing the gut to distension, which that is true. That seems to be pretty well established. So inflammation sensitizes the gut to distension, presumably because of increase in mechanoreceptors or increase in sensitivity. And so that would explain both why it feels like you always have to go, or that you will go but you still can't get everything out, right? Because you're really sensitive to any sort of pressure, and why you get diarrhea. Because again, even just a little bit is going to cause you to feel like there's a lot there, which is going to cause your bowels to move quickly. Kind of cool. Yeah. This is also, as I went down the rabbit hole, hypothesized to play at least a role in things like irritable bowel syndrome. Right? So irritable bowel syndrome, so it is established that 90% of people with IBS have heightened sensitivity to mechanical distension of the bowel. So one of the most tantalizing explanations for why, and at least it explains it in some of the cases, is that you get an inflammation or infection or something, so that will sensitize you to distension. And for unclear reasons, some people seem to be more likely to have persistence of that sensitization even when the inflammation is stopped, which is why they have to run to the bathroom so much, right? It's irritable bowel is like the equivalent of urgency for the urinary system, right? Which again, very similar idea. So if you've got inflammation of the bladder, you will have sensitization of the bladder to mechanical distension, right? So normally you have to distend your bladder a fair amount to feel like you need to pee. If you have inflammation of your bladder, even just a little bit of distension is enough to now make you think that you really have to pee and to set off the micturition reflexes. So again, my goal with this lesson was basically to try to give you general principles for thinking about these very common clinical phenomena and to try to help you to see the connections between them in a way that wasn't just you have to memorize it, which is why you see all these links to articles and PubMed IDs and stuff. Because I wanted to make sure that this was reasonably well established. Okay, questions so far?
Alec, can I go back to my point about serotonin? I don't mean to be a know-it-all about this. This is just literally the last question I did before our class started. So I found the UWorld explanation. Can I just read it out and we can make sense of it then? Like the line.
Yeah.
Yes, one line. Yeah, so conditions that cause BI irritation, example, infection, chemo, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferents. And then these then relay their impulses to the medullary vomiting center, inducing emesis. So is there? Yeah, so like I literally just did this question before class started, which is why it was like preying on my mind. So it seems as if there's like mucosal serotonin released. Yeah.
Sure.
And then, that's, and that's like, so the distension causes mucosal serotonin release, which hits 5-HT3 receptors. I think, I can copy the explanation.
Yeah, let me see. I don't want to, I don't know. The short,
I don't want to disrupt your flow or anything.
The honest answer is I don't know. It would be cool. I would love for that to be true, but I think I'd have to look into it more.
Yeah, you can look over it later.
Yeah. That's cool. No, I love the connection. So Ghana. So tenesmus. So again, tenesmus is the feeling of incomplete emptying when you're trying to poop. To use the proposed mechanism to explain why, like how the patient feels.
We're talking about how like when you have inflammation and it causes increased stimulation, it can cause tenesmus.
Yeah, exactly. Why would that make sense?
I guess that because if like the bowels or whatnot are moving too much, that you can't properly empty what's the word I'm looking for? You can't like properly get rid of all the poop.
So I don't know that it's so much. So maybe there is some effect of like you can't get rid of all the poop. Oftentimes, though, I think that you don't have to invoke that. Remember that with inflammation, you get sensitization of the nerves, especially to rectal distension. So even if, right, so normally you have to have a fair amount of stool in your rectum to feel like it's distended. If you had inflammation, do you think you would need more distension or less distension to feel the same degree of fullness?
Oh, you need
less distension. Yeah, exactly. So if you had enough inflammation, even if you didn't really have much there, it might feel like there was a lot there. Does that make sense?
Yeah, that makes sense.
So that would explain, because I had always memorized that inflammation causes tenesmus. You typically see that in something like UC or Crohn's, but you don't have to, right? And then I looked a little bit further and I was like, oh, actually, you typically see it in inflammatory bowel conditions. I was like, oh, so I can memorize that. But really, you don't have to memorize that. It actually makes total sense. Cool.
Yeah.
All right, so Moe, so can inflammation of the gut tube or its buzz cause nausea/vomiting? And why would that make sense? All right, we'll go to Paula. Paula, what do you think?
We're going to use the same like theory that we have been using. Since we have inflammation, then we're going to have sensitization like of the nerve. And this is going to cause like for the person to feel like bloated and to feel like distension. And then this is going to cause nausea.
Yeah, exactly. Yeah, because you're sensitizing all the nerves. So now a little bit of pressure is going to go a long way. Even though it's a little bit of pressure, your gut's going to think it's a ton of pressure. And so now it's going to think, oh gosh, there's some obstruction. We need to get this out. And you're going to feel nauseous. Like completely logic.
Thank you.
Yeah, that's cool. Nice. So Matan, so what is a good way to think about the GI causes? So let's sum it up. So the GI causes of nausea, vomiting. It's a good sort of general way.
So causes of inflammation.
Yeah.
Sorry.
Inflammation or what else?
Obstruction.
Yeah, obstruction. Yeah. Basically anything in the gut tube or its four buds that causes obstruction, so increasing pressure, inflammation, in other words, increased sensitivity to, or a toxin, right? You got to throw that in there. It's the GI tract. But yeah, basically obstruction, inflammation, or a toxin, which is cool. I remember the reason I came upon this was because I was looking at my chart. I was just kept vomiting. She was 4 or 5 at the time. And I was like a typical like doctor parent. I was like, let's figure this out. What's going on? Do I need to take her to the urgent care? So I was looking, I was like, oh wow, this is actually a really good way to think, really great way, some like random paper. It's a really good way to think about nausea vomiting, right? And that was basically what they said, obstruction or inflammation. I had the toxin thing. All right, Joni. So can a Appendicitis caused nausea and or vomiting.
Yeah, it's the same mechanism.
Yeah, same mechanism, right? Hepatitis. Yeah, Grace, what do you think? Grace, can hepatitis cause nausea and or vomiting?
Yes, also the same mechanism.
Yeah, same mechanism. Again, this is what I'm building towards because it was always really confusing to me. Gosh, can hepatitis give us nausea vomiting? Can esophagitis give us nausea vomiting? Can pancreatitis give us nausea? I don't know. Right? Now it's pretty clear. You can, and you've got a mechanism for why. So, Sujith, if you do not have nausea, can you say this is definitely not? No, unfortunately. It'd be so nice, right? That'd be so nice. If you could if there was something that was that sensitive, but no. The absence of evidence does not mean the evidence of absence. So unfortunately, no. Sue, so is all nausea vomiting caused by GI tract mechanoreceptors? Can you tie every cause to this mechanism? No, unfortunately. That'd be nice. That'd be super nice, but no, you can't. Yeah. However, I still think it's important to think about because again, a lot of the causes, particularly the causes that you're going to see on your test, and honestly in real life too, are going to be GI related. And when someone comes in with nausea vomiting, the first thing that everyone's going to think about is GI, whether it's true or not, it's GI. So it's a good way to schematize it in your head to know how to approach it. All right, so now we're going to tie this to coughing. So Saba, I'm going to make you an analogy, Saba. So nausea and vomiting is to the GI tract like coughing is to the respiratory tract. Right? So Saba, what's a good way generally to think about coughing and the respiratory causes?
I guess with the same concept of increased sensitization.
Yeah. So if inflammation or increase in pressure causes an increase in nausea and vomiting in the GI tract, what would cause an increase in coughing in the respiratory tract?
I'm sorry, my connection was in and out. Could you please repeat that really quickly? Sorry.
Yeah, absolutely. So we're saying that inflammation or pressure cause an increase in nausea in the GI tract. Would it be fair to say that an increase in inflammation or pressure in the respiratory tract could cause an increase in coughing?
Yes.
Yeah, for basically the same mechanisms. If nausea and vomiting is caused by obstruction or inflammation of the gut tube or its buds, then coughing is basically caused by pressure or inflammation in the respiratory tract, trachea, airways, or alveoli. So let's think about it. This comes up a lot. So Deb, what are the 3 most common causes of chronic cough in a non-smoker? So smoking obviously causes you to cough. You got, I guess, inflammation, maybe a little bit of pressure too, but definitely inflammation. So Deb, what are the 3 most common causes? Do you happen to know?
Postnasal drip.
It's pretty good, actually. GERD is the 3rd. So postnasal drip, asthma, and GERD. Great. This is one of those things that you should know because they're going to, especially for step 2, they're going to give you someone that comes in with a chronic cough that's not a smoker, and then they're going to describe to you basically, do they have GERD symptoms or not? Do they have asthma symptoms or not? Do they have postnasal drip symptoms? It's also a pretty common presentation in primary care clinics. So Zach, so bronchoscopy, right? So this is a bronchoscope, right? You stick a little fiber optic thing into their airways and you're trying to look at the different airways and get stuff from the lungs. So if you touch the side of the trachea or the bronchi with the bronchoscope, if I am snaking this in and I go boom, and I bash the side of or just lightly touch the side of the trachea, what's the patient going to do and why?
Start coughing and gagging because you put pressure.
Exactly.
And so it kind of mimics obstruction.
Yeah, and again, it's not really, so it's obstruction in the GI tract. It's not really like,
you said pressure and space.
You have a much lower threshold because normally there's supposed to be stuff in the GI tract. So it makes sense that you need a lot of pressure to get to the point.
So it's kind of relative,
Yeah, there's not supposed to be anything in your respiratory tract.
Yeah.
Even just a little bit. Yeah. So they cough like crazy. I can tell you this. Yeah. Having done anesthesia, it's, really, really, unless you deeply anesthetize someone, you just brush the side of the airway. They cough like crazy. So GERD, can this cause coughing and why?
Yes, it can cause coughing because you have pressure, you have irritation and inflammation.
Perfect. Yeah. So it's causing inflammation of the airways. Great. So you can sensitize the mechanoreceptors so you will cough more. Great. All right. So Vi, so asthma, can this cause coughing and why?
Yes, because you have inflammation of the small airways.
Perfect. Yeah, exactly. Yeah. What's interesting is that there was I think it was like a NEGEM paper not too long ago where they looked at like the difference between like inflammatory and non-inflammatory asthma and to see who responded better to steroids. And it's, answer, but inflammatory asthma responds much better to steroids, as you can imagine, presumably for this exact reason, or at least partially this reason. So you get inflammation of the airways, so you presumably you're sensitizing the mechanoreceptors, and so you'll increase your coughing. Great. Leah, so postnasal drip, can this cause coughing and why?
Yeah, a similar reason. You have the postnasal drip's going down your throat and it's irritating. And so you're, again, similar sensitization going on, and then you're going to cough.
Yeah. In this case too, I think you also have the mechanical effect of like you have mucus. There's like stuff there. So presumably that's going to cause coughing too. But yeah, I assume there's some inflammatory component as well. So Agana, what would be the likely etiologic mechanism of a dry cough? Because you see this a lot. And like when I was a medical student, it never made sense to me, like dry cough, wet cough. Why productive cough? Like, why does that matter?
I think it matters because with the productive cough, you have an over secretion of like the glands, which causes like the mucus to stay and you have to cough it up. I feel like a dry cough, there's some kind of irritant, but it doesn't cause like mucus to be built up.
Yeah, exactly. Either because of inflammation or because whatever that is there can't be easily coughed up.
Yeah.
But the more likely thing, usually it's because of just inflammation, right? It's often inflammatory, which again would make sense if you sensitize the mechanoreceptors. That's why even just like a gust of cold air can cause you to have bronchospasm if you're an asthmatic. All right, so I want you guys to update your pathophysiologic chronologies and we will talk about it. So what I'm going to do is, again, so instead of just reading it, I'm going to actually read it and analyze it as if I was going to do it myself. So got a young guy, has a 1-week history of fatigue and nausea with 2 days of yellow skin. So he's got jaundice for 2 days. So a week ago, he started to having fatigue and nausea. So vague symptom, although probably more GI. And now you've got some skin yellowing. So you're thinking already GI, either obstruction or inflammation. His past medical history is unremarkable. So healthy guy, no bad habit. He works in a restaurant. So could be nothing, but exposed to like foodborne pathogens, potentially. His temperature is normal. Heart rate is normal. Blood pressure is normal. So vitals are normal. He's got jaundice. There's something going on with his liver because it's large and it's not tender. And so he's got no signs of basically like cirrhosis. So the labs are really going to be the key then. So already, I don't know. I guess you'd be thinking at this point, maybe something to do with the liver. I guess you'd probably be thinking hepatitis, but you wouldn't necessarily know. Hepatitis would certainly make sense with the restaurant thing because it's fecal oral transmission. So that would make sense. This is where the money is. So he's got about a little less than 50% of his total bili is direct bilirubin, which both are elevated. So that tells you that's something going on in his liver. He's got much higher elevations of his ALT than his alk phos. You could do the R factor, but again, this already is above 5 times the ALT over the alk phos. So already, even without multiplying it by 3.5, you should already, this is very clearly intrahepatic. So he's got no signs of liver failure, either acute or chronic. And this is telling you, so anti-HAV IgM. So this is positive. So this tells you that he's got an acute hepatitis infection. Because again, hepatitis A, we'll talk about this probably next time or one of the future ones, but hepatitis A only gives you acute infections. So if you get IgG, it tells you that you've had hepatitis in the past or you've been vaccinated. So the fact that he's negative means that he was not exposed previously, and this is an acute infection. Because if he had IgG, this would be a protective antibody. The fact that he's got anti-surface antibody tells you that he was exposed to hepatitis B in the past. The fact that he doesn't have an anti-core antibody tells you that he was vaccinated. So he was vaccinated against hepatitis B. And so, because he also has no surface antigen. Had he been exposed to hepatitis in the past, like a live virus, and he was infected, but he cleared it, then both of these would be positive and the surface antigen would be negative. So he's got an acute hepatitis A. So this is my pathophysiologic chronology. I basically just walked you through the first part of this. Again, the nausea vomiting makes sense because you've got inflammation in the liver. So you got sensitization, presumably of the mechanoreceptors. And so Zach, very graciously shared this gem. So he said, the choice of antiemetic therapy depends on the source of the emetogenic stimulus. Conditions that cause GI irritation, so infections, chemotherapy, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferent nerves. These then relay their impulses to the medullary vomiting center, inducing emesis. So that's great. That's actually really useful. So it would make sense that the common mechanism here would actually be 5-HT3. So you're sensitizing the mechanoreceptors. And so now the mechanoreceptors are more likely to cause release for less distension, you'll have more release of serotonin. So that is why you will have nausea. The acute infection, as we talked about, is why you have IgM. And then because he's had a prior HPV vaccination, he was exposed. The vaccination, the key thing to remember is that the vaccine is surface antigen, but no core antigen. So because of that, you'll make an anti-surface antibody, but because you're not exposed to the anti-core, you're not exposed to the core antigen, you will not make an anti-core antibody. So this is our summary of key concepts. I won't belabor it. We went over it, but we will include that in the notes. So questions, concerns, thoughts?
This is a random question, but is nausea is it lessened at all in diabetic patients who have like diabetic gastroparesis or anything like that, or is it altered?
I don't think so. That would be interesting. If you told me that there was a case study of someone with diabetes who, like, I don't know, had knocked out the afferents from their GI tract, and you could blow tons of air into their GI tracts and they'd never get nauseous and distend it like crazy. Yeah, I have no reason to disbelieve that, but I don't know that's like a thing.
Thanks. I'm just curious.
Yeah, good question. Other questions? Asaba says that was super helpful. Thank you. Oh, great. But what was helpful specifically?
Just the way that we like described everything, I really appreciate like having a systematic approach to think through things, because I don't know, tackling things without a clear strategy in mind I don't think that's anyone's first choice approach. But yeah, I just really can't emphasize how much I appreciate like giving us like a structured approach to these kinds of questions for like tests and.
Awesome. Thank you. Yeah, I feel the exact same way. Yeah, I felt like I learned a lot of this stuff in very like haphazard ways, and I had to piece together with like gum and twine, like a general approach. But yeah, it's interesting. It's much more pleasant. Like it's just much more fun to practice medicine or to do questions or things when you have a systematic sort of way of thinking about it. Cool. Awesome. Thank you guys so much. Again, we are continuing on with GI. I think there may be a point in which we may branch off a little bit and do a little bit of question interpretation, or I've also noticed there's two sort of steps with Anki. So one of the steps, and just like learning material in general, the first step that is already a difficult hurdle to clear is, if you get a fact, can you make sense of it and make a good card? So if you get this random fact, I don't know, inflammatory bowel conditions, oftentimes you get tenesmus, right? Can you make sense of that? Can you do something where you can make sense of that? That in and of itself is pretty hard. Most people don't do that. They'll just memorize that. And so you're left without a systematic benefit to knowing that fact. I've noticed that a lot of people struggle with that. I've also noticed, though, that a lot of people really struggle with the idea of mastering a broad topic. So I'm probably going to have something in the course, either in the course or lessons or both, where we talk about like where we actually practice this, because I think it's really important. I will say for people whose scores do not improve, I would say the number one reason is they're just not really learning things very well, or they're not really retaining it very well. That's almost always, especially if your scores are stuck at lower amounts, like less than 220, 210 for either step, but especially for step one, it's pretty common to see that being a major problem. So thank you guys very much. I will see you guys next week. If this clicked for GI, the next video shows you how to think this way across the entire exam. You'll learn the framework that prevents missing questions you already know, and how to guarantee 90+% on every topic. Click here to watch how to virtually guarantee a 260+ in step 2, and see how students went from failing to scoring in the top 10, 5, or even 1%.